All right. Assalamu alaikum, everyone. My name is Rawad Turko. I'm a fourth year medical student. And today, inshallah, we'll be doing a clinical neuroanatomy crash course. So I'll be taking you through almost all of your lectures in anatomy, all of your neuroanatomy lectures. And we're going to be focusing on purely the clinical points. So I might explain a couple of the concepts in anatomy just because they relate or they're pretty important to understand the clinical points, but I'm not going to be going through all of the anatomy. So be sure to watch this PAL only after you've studied everything and only after you feel like you have a good idea of all of the general anatomy. Okay, so it's going to be a lot of lectures, so this might be a bit of a longer PAL, but inshallah we're all good. I've got my notes here to kind of guide me through the whole thing. And yeah, let's get right to it. So we're going to start with the development. All right, and we're going to start with neurulation. Okay, so we know that at around the third week we have the three main parts that are the ectoderm, the mesoderm, and the endoderm. So now let's imagine that we're looking at a superior view of this plate, and we have here the cranial end and the caudal end. Okay, and again, this is the ectoderm. What we're gonna have is that we're gonna have this thickening of the ectoderm that's forming here, and that's called the neuroplate. Now, this is gonna happen at around day 17. Okay, so this neuroplate eventually is going to be basically form into neural folds and a neural groove. And what's going to happen is that this neural plate, this thickening, it's going to fold over itself and it's going to eventually form a neural tube. Okay, and this neural tube is going to be induced by something called the notochord. And you guys can see that here. This is the notochord. Yeah, this is the notochord here, and you can see this thing, this round thing, this is called the notochord, and it's going to be inducing the formation of this neural tube. So if you can see here, if you follow along with this diagram, at around day 17 or 18, this starts to form. So the neural fold is going to be folding over itself, and you're going to form this neural tube. And then this neural tube is going to form around the posterior, I guess the midline, and then it's going to continue fusing both in the cranial direction and the caudal direction. Okay, and eventually both of those neuropores are going to close. So again, they're going to be forming up and down, like cranially and caudally. And you're going to have eventually just before those two ends fuse, you're going to have the cranial neuropore right here, which is just like the last little opening left in the neural tube, and the caudal neuropore. Okay, so the cranial neuropore eventually is going to close at around day 24. The caudal neuropore is going to close around day 26. All right. And then right above the neural tube, you're going to have this layer of cells that are going to sort of, form they're going to be on top of the neural tube, and these are called your neural crest cells, which are important for a lot of the other processes that happen into the body. We'll talk about those in a minute. Okay. So again, just to repeat what we sort of discussed, so neurulation because of the, sorry about that. Just give me 1 second, guys. Just got a little warning on the phone. Um, Anyways, so what were we saying? Neurulation begins in the third week of development. That's something we know already. The notochord here, which we see here at the bottom, same thing that I pointed out right here. That's what induces the formation of the overlying ectoderm. Again, that we said that the entire nervous system is going to form from the ectoderm, or specifically the neuroectoderm. All right, to form the neural plate. And by the end of the third week, the neural folds grow over the midline and fuse to form the neural tube. We have the cranial neuropore closes by day 25 and day 27. Again, there's a little bit of, here they say 24, 26. It's around the same time. Okay, 25, 27, 24, 26, whatever. Okay, so again, this is the clearer picture of what we're looking at. And then these cells here at the top, these are your neural crest cells. Okay. Again, so right now we're looking at again at the neural tube. So this is the neural tube that we're talking about. We have this, and this is where the CSF would be, the cerebrospinal fluid. This is where it would be in the middle of this neural tube. Now right here we have this expansion that's sort of like a lateral expansion called the sulcus limitans. Now the sulcus limitans is going to basically separate the basal plate from the alar plate, or this is basically in other words, the motor plate from the sensory plate. Okay. So again, we said we have the basal plate here, which is again another word to say the motor plate, and the alar plate, which is the sensory plate. Okay. Another important thing that we have to know is that the formation of both these plates are through different signaling factors. So for the basal plate, it's through the SHH, which is the sonic hedgehog gene. All right. And then the alar plate, or the sensory plate, is it's formed through signaling of BMP, which is bone morphogenic protein. Okay, and then you have the sulcus limitans here. Just know that it separates basically the alar plate from the basal plate, or the motor plate from the sensory plate. Okay, and if you actually, this is a bit of a fun fact, but if you go up actually to the medulla, you will see a continuation of this of this sulcus limitans that's going to separate, again, the motor nuclei from the sensory nuclei. You'll see that in the, I think, in the caudal medulla or something like that. All right, so this is just something that you have to know. These are, again, signaling factors that sort of induce formation of all these different, sorry, all these different things that we see in the nervous system. Okay, now the neural tube eventually it's gonna it's gonna form three primary brain vesicles, which are then going to transform to five secondary brain vesicles. So we have the prosencephalon, which is another word for forebrain. We have the mesencephalon, which is another word for midbrain, and we have the rhombencephalon. Okay, the prosencephalon eventually is going to form the telencephalon, which gives rise to the cerebrum. The diencephalon, which gives rise to the thalamus, the hypothalamus, and the epithalamus. Now, this is important to remember the diencephalon, okay, and all of its all of its products. Mesencephalon is gonna also give us the mesencephalon, which is the midbrain. This is the easiest one to remember. And then the rhombencephalon, or the hindbrain, is going to give us the metencephalon, which is then going to form the pons and the cerebellum, or the little brain, and the myelencephalon, which is going to form the medulla. All right, so this is again something that you have to know. All right, moving on to some questions. Pause the video, take a second, and try to answer this. So, what is the diagnosis here? So this is hollow prosencephaly. Okay, so we said here that the prosencephalon is going to form the telencephalon, which is going to form the cerebrum. Part of the formation of the cerebrum is the formation of this midline sort of thing that can separate the lateral hemispheres, or like the two cerebral hemispheres. So if we don't have that, we have this thing called this disease, this very tragic disease called hollow prosencephaly. So again, what's the pathophysiology? Take a second also to answer it. This is a midline developmental defect causing abnormal separation of the neural tube without development of the two hemispheres. Okay. What gene mutation is implicated in hollow prosencephaly? So again, this is the sonic hedgehog gene. Okay, you'll find that the sonic hedgehog gene and also the homeobox gene are implicated in many of the disease processes that we see in the nervous system development. Okay, and the hollow prosencephaly can be seen in which chromosomal disease? So that's Patau syndrome, which is trisomy 13. Okay, this is a like a classic link. This is a classic association that you have to know. Okay. Now moving on, what's the diagnosis for this? So you'll see here like there's a smooth brain. There's not a lot of sulci or gyri. So this is lissencephaly, okay, or people call it smooth brain. So what is the pathophysiology? So this is caused by failure of neuronal migration during brain development. Okay, so we know that part of your development of the nervous system is that we have these neurons that are going to migrate using these radial glial fibers. So the radial glia, they're basically these neurons are going to use microtubules in order to, I like to think of it as like walking up these radial glial fibers. So these radial glial fibers act sort of like anchors, and they sort of pave the path for these neurons to migrate. So if there's failure of these neurons to migrate, this can lead to lissencephaly. What gene mutation is implicated? So this is the DCX gene, something you have to memorize. And what is affected? So this is microtubule dysfunction in migrating neurons. So we have impaired neuronal migration along radial glia. Okay, so again, the main point that I want you to know here is that part of the nervous system development, you're going to get these neurons that are going to migrate along these radial glial fibers. And if you have a mutation in this DCX gene, which I guess produces something to do with the microtubules, then you're going to have microtubule dysfunction, which is going to have impaired neural migration. Okay. Now, what type of cells are these? These ones right here on top of the neurons. So I mentioned these before. So these are your neural crest cells again. What do they form? And you can name any four structures that you can remember. So melanocytes, adrenal medulla, Schwann cells, and neural ganglia. By the way, important thing, this is a bit of a sidebar, but important thing, when we say neural ganglia and we say neural like nuclei, for example, the difference between ganglia and nuclei is that ganglia is a collection of cell bodies in the peripheral nervous system. So it's not in the central nervous system. But if we say it's like something is a nuclei, like when we're talking about cranial nerve nuclei, for example, this is a collection of cell bodies in the central nervous system. So either in the brain or in the spinal cord. Okay, so that's just the main difference. So that's why these neural crest cells form the neural ganglia, all right, because they're in the peripheral nervous system and not in the central nervous system. Okay, now which disease occurs as a result of a failure of these cells to migrate? Now there's a bunch of different diseases that you can think about, but there's one really main like classic disease that you should know. That's Hirschsprung disease. Okay, so what's Hirschsprung disease? This is colonic like mega dilation, I guess, because of because of a failure of these neural crest cells to migrate, which forms basically atony of the distal gut, and that forms like an oversized megacolon. What gene mutation is implicated in Hirschsprung disease? That's the RET gene mutation. All right. Okay, now let's move on to the development of the pituitary gland. Now you all must have heard before that the pituitary gland is actually a little bit different because we have because it comes from oral ectoderm, in comparison with other neural structures that come from neuroectoderm. Okay, and that's partly true, but the main thing to remember is that the pituitary gland is made up of two different parts, the anterior pituitary and the posterior pituitary. The anterior pituitary, or the adenohypophysis, is actually the one that's formed from the oral ectoderm, which is Rathke's pouch, all right, coming from the stomaderm. But the posterior pituitary, or the neurohypophysis, is actually coming from neuroectoderm, or from what I'm like. It's the same thing that forms the rest of their nervous system, and this is basically a extension, I guess, of the median eminence that you see here. Okay, that's forming the hypothalamus. Okay, so this is eventually what's going to form. You have the oral ectoderm and the Rathke's pouch here. Rathke's pouch is going to migrate out upwards, and the infundibular process here of the neuroectoderm forming the neurohypophysis is going to migrate downwards, and eventually they're going to meet each other, and they're going to sort of entangle around one another, and they're going to form the pituitary gland, which can be split into the anterior pituitary and the posterior pituitary. Okay, this is something that you should know. So now we're moving on to pituitary anomalies. So we have two things that we wanna know. First one is the pharyngeal hypophysis. This is the persistence of hypophyseal diverticulum in the roof of the pharynx. So instead of the pituitary migrating upwards, it sort of stays in the roof of the pharynx, and it's going to form something called the pharyngeal hypophysis. So pharyngeal because it's in the pharynx, it's not really where it's supposed to be. Craniopharyngioma is the one that's a lot more high yield, the one that tends to pop up more in question banks. So it's an aberrant outpocketing of the stomadeum and develops in the pharynx along the path of the hypophyseal diverticulum. The symptoms of craniopharyngiomas may resemble pituitary adenomas. So this is what it's going to look like. A craniopharyngioma, the main thing that they want you to know about a craniopharyngioma is, first of all, it's formed from surface ectoderm. So this is remnants of Rathke's pouch. And second of all, there's a lot of cholesterol that's usually in these craniopharyngiomas. So on MRI, you're going to see a sign that's sort of going to be described as like a motor oil sign, or something that looks like motor oil in the brain. Just know that that's a craniopharyngioma. And because it's a tumor, and it's actually specifically a childhood tumor, it's going to resemble pituitary adenomas. That's because it might compress, and it also could cause hypopituitarism, just because the pituitary gland is not able to secrete all of its product because of this pressure from the craniopharyngioma. Okay. Now, who can tell me the diagnosis here? We already said it here, herniated cerebellum, so it should be very easy. So again, that's Chiari-1 malformation. What's the main difference? Here you just have the cerebellar tonsils, whereas in Chiari-2, we'll talk about it in a minute, but just know that this is a herniation of specifically the cerebellar tonsils, okay, not the entire cerebellum, through the foramen magnum. So the foramen magnum is where the spinal cord is going to enter in order to become the brainstem and the brain and everything else. So if you have herniation of these cerebellar tonsils through the foramen magnum, this is called a Chiari-1 malformation, or an Arnold Chiari-1 malformation. That's the full name. So what's the pathophysiology? It's the congenital downward herniation of cerebellar tonsils due to a small posterior fossa. So this is here, the posterior fossa. Usually there's a lot of space here. There's a lot of space for the posterior fossa for things to sort of fit all together. If it's very compressed in there, then things like, for example, a lumbar puncture, which is going to relieve a little bit of pressure from the spinal cord, is going to cause a herniation of the cerebellar tonsils, just because there's not enough space for them to, because of this pressure difference, there's not enough space for them to go in the posterior fossa, so they're going to herniate downwards. Sorry. What's a common association with a Chiari-1 malformation? This is a syringomalia, which I'm not going to talk about too much right now because we're going to touch upon it later. So just know that this is an association for now. If you studied all the lectures, you should know by now what a syringomalia is. Okay. Now, what's the difference between Chiari-1 malformation and Chiari-2 malformations? Downward displacement of the cerebellum and the brainstem through the foramen magnum. Okay, so in Chiari-2 malformations, parts of the brainstem as well are going to herniate down the foramen magnum. So it's a lot more dangerous actually, Chiari-2 malformations because of this displacement. And what's a common association? There's actually two common associations that you should know for Chiari-2 malformations. The first one is a myelomeningocele or a neural tube defect and a non-communicating hydrocephalus. And again, that's because your fourth ventricle here is going to be compressed, or sorry, the fourth ventricle is going to be compressed. So you're going to have a non-communicating hydrocephalus in infanthood or childhood, early childhood. Okay. All right. And then what's the diagnosis here? Who can tell me? So this is anencephaly. Okay, so what's the cause of anencephaly? This is a defective neural tube closure in the cranial neural pore. Remember before when I said that you have your neural tube that's going to fuse cranially and caudally, and it's going to form these cranial and caudal neural pores, and then those are going to fuse. Now, a defection in the cranial neural pore to fuse is going to not allow the forebrain to develop. Now, if the forebrain does not develop, you're going to have anencephaly. So, an basically meaning none or no. So there is no encephaly, which is there's no formation of the forebrain, and therefore this is incompatible with life and encephaly. Okay, elevated levels, I should say elevated levels of which biomarkers are seen in these cases. It's alpha-fetoprotein, something I have to remember. Which form of anencephaly is characterized by additional failure of neural tube closure in the posterior midline? So imagine you have anencephaly, which is a failure of the cranial neural pore to close, but in addition to that, you also have failure of the neural tube to close in the posterior midline. That's craniorhachis. Okay, so again, craniorhachis, you have basically just an open neural tube. So the neural tube just does not fuse, and this is absolutely incompatible with life. Okay, and what reduces incidences of neural tube defects, or in this case, anencephaly, folic acid supplements during pregnancy, and actually right before pregnancy too. Okay, so now we're going to talk about neural tube defects. So again, craniorhachis is already talked about. It's a completely open brain and spinal cord, so the neural tube does not close at all. Anencephaly, open brain, and lack of a skull vault. Encephalocele is a herniation of the meninges and the brain. So the seal is a herniation, or it's like a cyst. You can imagine it like a cyst. So if it says encephalocele, it means herniation of the brain, of the meninges and the brain. Encephalo basically meaning brain. This one I blocked out just because you guys didn't take it, so it's not important to know. Spina bifida, and now we get to the spina bifidas and the caudal neural tube defects, which are a lot more important that you have to know. So you have spina bifida occulta. This is the first one. This is basically just a bony defect. Okay, so it's a closed asymptomatic neural tube defect in which some of the vertebrae are not completely closed. Okay, and this may be completely silent, or in some kids you'll see either a tuft of hair or like a little bit of dimpling in the lower back, and that's what spina bifida occulta is. Okay, it's completely harmless. Then we have meningocele, which is seal, so herniation, meninges, so it's herniation of the meninges. Okay, so you see here the spinal cord is still intact. It's still within the confines of the spinal cord itself. So there's a protrusion of the meninges filled with CSF through a defect in the skull or spine. And then we have a myelomeningocele, which is an open spinal cord. So this is meninges with the actual spinal cord inside of this herniation, side of this cyst. Okay, and all of these can be prevented with avoiding vitamin A during pregnancy, and also with folic acid supplements during pregnancy. Okay. All right, so who can tell me the diagnosis here? So this is obviously an infant child with hydrocephalus. We know that for sure. But look at this MRI here, something else noteworthy. Look at this, all of this empty space. So this is Dandy-Walker syndrome. So what is exactly Dandy-Walker syndrome? So Dandy-Walker syndrome, sorry, or malformation. It's a couple of different things. So first of all, you're going to have a cyst that's going to dilate the fourth ventricle. So there's a cyst. We know that we have the ventricular systems. We have the lateral ventricles that drain into the third ventricle drains to the fourth ventricle. If we have a cyst in the fourth ventricle, there's going to be this large outpouching of this ventricle. And because of this outpouching of the fourth ventricle, you may have either hypoplasia or complete absence of the cerebellar vermis, which is the anterior portion, I guess, of the cerebellum. And also because of the dilation, you're going to have enlargement of the posterior fossa. Okay, so all of this symptoms that you see in Danny Walker syndrome or Danny Walker malformation can be explained by the pathophysiology. So because you have absence of cerebellar vermis, you can see things like truncal ataxia. You can see like poor motor posturing or poor motor learning. Um, because of the because of the dilation of the fourth ventricle, you're also going to have a hydrocephalus. So again, there's movement abnormalities and there's hydrocephalus. It's treated with a VP shunt. And this is a really nice mnemonic here. So DWS or Dandy Walker syndrome. So D is for dilated fourth ventricle. W is for water on the brain, which basically is just hydrocephalus. And S is small or absent vermis of the cerebellum. Okay, so this is Dandy Walker syndrome. All right. Now, this is all the clinical stuff from your first lecture, the development lecture. Now we're going to move on to cells and organization. This is a bit of an easier lecture to get through just because there's not that many clinical correlations. So we're going to talk about the neuron and the different parts of the neuron. So this is a neuron. This is the cell body here, or the soma. People call it the soma, this thing in the middle. We have these dendrites that collect information. So these receive stimulus from other neurons, carry it down to the cell body or the soma. All right, and again, here you have the nucleus in the middle. Then this is going to basically transmit the signal down into the axon, and the axon could be myelinated or it could be unmyelinated. So right here you have Schwann cells. I guess in this case, these are Schwann cells, and they're separated by these things called nodes of Ranvier. The nodes of Ranvier is what allows for saltatory conduction, which speeds up the stimulus down the axon of the terminal. And here at the end, you have the axon terminal, where you have this all of the nerve stimuli basically being transmitted to other neurons in the process. Okay. And we do have to know a couple of these organelles in the neurons just because they're important. So Nissl substance is something that you're going to hear a lot. Just basically remember it as the rough endoplasmic reticulums plus the ribosomes. So those two together we call the Nissl substance in neurons. Golgi apparatus, we already know what it does. Protein modification and packaging. Mitochondria, obviously for ATP production. Microtubules for axonal transport tracts. So you can either have anterograde or retrograde transport. So either things going down the axon terminal, which is called anterograde, or things going back up, coming back up towards the cell body, that's called retrograde. So kinesin is basically the protein that is responsible for anterograde transport, and dynein is for retrograde transport. This is pretty important to know for later on in some of your other blocks, inshallah. So just keep this in the back of your mind uh, for your following blocks. Lysosomes for degradation of cellular components. Synaptic vesicles, obviously we know that we have neurotransmitters that are released from neurons. So we have storage and release of neurotransmitters. Endosomes is for vesicle recycling. The axon hillock is the action terminal initiation zone. So that's right up here. And the important thing to know is that there's no Nissl bodies in the axon hillock. Nodes of Ranvier for saltatory conduction, and MAPS or microtubule associated proteins. These are things that stabilize microtubules and regulate axonal transport, like the tau protein, which is an important thing that we have to keep in mind. Okay. All right, we have a 75-year-old patient with memory loss and the following biopsy findings. What's the diagnosis? Take a minute. So this is Alzheimer's disease. Okay, so what are the arrows pointing at here? What's being, what are we pointing at right here? So these are neurofibrillary tangles, all right, which are hyperphosphorylated tau proteins. So tau, like I mentioned back here, there are microtubule associated proteins. So these tau proteins can be hyperphosphorylated in Alzheimer's disease, and basically they can form these sort of neurofibrillary tangles, which is very important to look at when we're looking at the biopsy finding. There is another biopsy finding that's important though. So what's another classic biopsy finding in Alzheimer's disease? These are your neuritic or senile plaques made up of beta amyloid. Okay, so something important to know. So you have beta amyloid making your neuritic plaques, and hyperphosphorylated tau protein making your neurofibrillary tangles. All right. Now, in Alzheimer's disease, loss of neurons are seen in which area, specifically in the brain? So we have the hippocampus, the temporal-parietal cortex, and the nucleus basalis of Maynard, which is basically where all of your cholinergic or your acetylcholine neurons are. They're in the nucleus basalis of Maynard. Okay, this is something to know. That's why we treat Alzheimer's disease with acetylcholine esterase inhibitors, okay, because of damage to this nucleus basalis of Maynard. All right. Now moving on to neuronal response to axonal injury. Now let's say we have this long neuron here and we have damage right here in the middle. All right. Distal to this damage, we're going to have something called the Wallerian degeneration, which is distal axon segment and associated myelin sheath disintegrates with macrophages removing the debris. In the CNS, persistence of the myelin debris and reactive gliosis, prevent axonal regeneration. Okay, now that's distal to the site of the damage. But proximal to it, you're going to have the axonal retraction. So the axonal retraction is basically just proximal axon. It's going to retract and sprouting new protrusions that grow towards other neurons for potential reinnervation. Okay. So again, this proximal segment is going to form new, new axon segments in order to connect to other neurons since you have degeneration of the distal segment. All right. Now, in the cell body itself, in the soma, you're going to have this process called chromatolysis. So you're going to see a couple different things. The dispersion of the Nissl substance basically is just because your Nissl substance, which is made up of your rough endoplasmic reticulum and ribosomes, they're preparing to form more proteins so that you can have this response to injury. Okay. And then you're going to have displacement of the nucleus to the periphery, and you're going to have cellular swelling. Okay. These are all things that you're going to see. Okay. Dispersion of the Nissl substance throughout the cytoplasm, neuronal cell body react. Again, this is to increase protein synthesis and swelling and displacement of the nucleus to the periphery. Okay. And we have the rest of this. Now, again, this is all about everything we talked about before. It had to do with the neurons. Now we're going to get into the glial cells or the other cells in the nervous system. We have oligodendrocytes in the central nervous system that are going to form myelin sheaths. So this is responsible for the myelination of the neurons. We have the microglia, which are basically just modified macrophages. We just call them microglia in the central nervous system. So they have the same function as regular macrophages, so they're scavengers. We have the ependymal cells, which do a couple different things. First of all, they create barriers between compartments, and they're a source of neural stem cells. Also, the ependymal cells in the walls of the ventricles can also produce CSF or cerebrospinal fluid. Okay, now finally, I left astrocytes to the end because it's the most important one. They have a couple different functions. First of all, they form support for the central nervous system. They help form the blood-brain barriers, or specifically the foot processes of these astrocytes, these things that you see here. They're the ones that help form the blood-brain barrier. They secrete neurotrophic factors, so things that can basically help with neuronal repair following injury. And they take up potassium and neurotransmitters. Okay, so they just take up neurotransmitters in the synaptic cleft if there's any leftover neurotransmitters in that area. Okay, and again, we said oligodendrocytes make up the myelin sheaths in the central nervous system, but do we know what forms myelin sheaths in the peripheral nervous system? I think we mentioned it before. That's your Schwann cells. Okay. All right, moving on to the third lecture, which is spinal cord and tracts. We're going to start with just talking about the vertebra itself. So again, we have the vertebra here. We can split into the cervical region, the thoracic region, lumbar, and then the sacral curve or the sacral vertebra. But the main thing that you have to know about any vertebra is that you have here the body, the vertebral body, and then you have this whole thing here, which is basically a pedicle that's connecting to a lamina, and you can have transverse processes. Now, how do you tell the difference between cervical, thoracic, or lumbar vertebra? The cervical vertebra, something to know about the cervical vertebra, is that it has an oval body and a triangle-shaped foramen. So you see here, there's an oval, no, this is, yeah, right here. There's an oval body, and the foramen has a sort of triangular shape. For the thoracic vertebra, it's a heart-shaped vertebral body and circular foramens. So you see here the heart-shaped ones and the circular foramens. Lumbar vertebra, it's a bean-shaped body, as you can see here, and it has a flattened triangular shaped foramen. So it's similar to the cervical when we're talking about the foraminal shape, but it's much more of a flattened triangle, I guess you could say. Okay, and again, these are the different parts of the vertebra. You have the vertebral body here. These are the pedicles, the transverse processes, the superior articular processes, the lamina here, and then the spinous process. Okay. All right, moving on. So the spinal cord itself ends at around like the level of L1 and L2, or L2 in adults. The tapered end of the spinal cord here is called the conus medullaris. Okay, from this tapered end of the spinal cord, you have a couple of different structures exiting. First of all, you have this sort of thin thing called the filum terminale. The filum terminale acts as sort of an anchor, so it's made up of fibrous tissue, and it's sort of anchoring the spinal cord to its place. So again, it's extending from the conus medullaris, as we mentioned, and you have the cauda equina, or the cauda equina, like it's all the rest of the spinal nerve roots that have to exit and innervate the rest of the lower body. Okay, since it ends at level L1 to L2, the rest, or the cauda equina, or the horsetail, that's what a cauda equina means, is basically just the remaining spinal nerve roots that have to exit out of this level. Okay. Now, because the spinal cord is a lot shorter than the actual vertebral column, there is a bit of a discrepancy between what spinal segment we're talking about, like for the spinal cord, and what vertebral level we're talking about, which we're gonna get into right here. Okay, so again, we mentioned that the spinal cord is a bit shorter than the vertebral column. That means that we can't look at, for example, like T12 and be like, oh, at T12 we have the spinal nerve root from T12 exiting. No, because it's a lot shorter. Okay, so this is just a table for you guys to make your calculations. So for the cervical vertebra, we can add one, and that's because here the nerve root is going to exit above its corresponding vertebral body. So for example, C1 is going to exit right above the C1 vertebral body, C2, C3, C4, whatever, up until C7. And then we have T1, but above T1, you're going to get C8 exiting. So, okay, so this is different. We don't have a C8 vertebral body, but we do have a C8 a C8 spinal nerve root. Okay, and that's why in the upper thoracic vertebra we're going to add two. Again, you're going to add three here, and then just follow the rest of this table to know how to do those calculations. Okay, but the basic point of this is that the spinal cord ends at level L1 to L2. So there is a discrepancy between what spinal segment and what vertebral level we're talking about. Okay, and this is the table for you guys to sort of memorize as best you can. All right, now let's take a look at a cross section of a spinal cord, or a part of the spinal cord. Okay, here we have white matter in the periphery and gray matter sort of in the center. Now, I know if I ask you guys this question, what's the difference between white matter and gray matter? You're going to tell me, well, white matter is the tracts and gray matter is the cell bodies, and that's not untrue. That is true, but it's partly true. So, what makes white matter white? That's myelin. Okay, so the myelin sheaths, or the myelination that we see in these long tracts, is what makes the myelin or the white matter white. Okay, the gray matter is gray because it has, like we mentioned, cell bodies. But let's say we have like unmyelinated neurons, things like interneurons. Interneurons are also we can see here, there's literally interneurons in this diagram. So interneurons are also in the gray matter, and that's not because, this is a faulty, I guess, or a misnomer of gray matter or white matter. It's because these short interneurons are unmyelinated, so they can form the gray matter. Okay, so again, white matter is myelinated long tracts. So the long axons of very long tracts are going to make up the white matter. Gray matter is dendrites, unmyelinated, or dendrites, cell bodies, and short unmyelinated complete neurons. Okay. We have here the dorsal section. We have the ventral section here, and in some parts of the spinal cord, we have an intermediate zone here in the middle, which we're going to talk about in a minute. Okay, but the dorsal part we already know gives rise to the dorsal roots, which is where all of your sensory neurons are going to be coming in. So all of the sensory neurons are going to collect information from your hand, for example, and it's going to go up to the dorsal root ganglion. That's where all of again, we mentioned ganglion as a collection of cell bodies in the peripheral nervous system. So all of these cells are all these cell bodies are in the dorsal root ganglion, and then they're going to come up and they're going to synapse, or they might not synapse. They might just go to the dorsal horn, and then they might ascend. They're going to ascend up to the brain. So that's all of that's happening in the dorsal root. Ventral root is the motor part of the spinal cord. So that's where you're going to have your lower motor neurons exiting at the anterior gray horn. And once these neurons, or once these nerves exit out of the anterior gray horn, they're going to mix. So here you have this sort of spinal nerve that's exiting out of the spinal cord, and this is going to be mixed, both sensory. It's going to have a motor component, and it's going to have a sensory component, as you can see here. Okay, and then it's going to form these rami that you can see here. So you have a dorsal ramus and you have a ventral ramus. Okay, and the dorsal ramus, I guess they want you to know that it supplies the motor and sensory innervation of the skin and the muscles of the back. Again, we mentioned innervation of the skin because there's a sensory section and a motor section, so it's going to innervate the muscles of the back. Okay, so this is just basic anatomy of the spinal cord. Okay, now to go into a little bit more detail. Again, right now we're going to talk about purely the white matter. We mentioned before that white matter is just the long tract, the myelinated long tracts, okay? And because they're tracts, because there are very long tracts, they're either going to be ascending pathways or descending pathways. Now, rule of thumb, at least just for the sake of this lecture and for like basic neuro stuff, ascending pathways are all things that are sensory. So all sensory pathways are ascending pathways, and obviously they're sensory, so they're carrying information from the extremities or from from the extremities or from wherever, from your skin up to the brain, so that you can process this brain, and there can be integration of this information. Descending pathways are coming down from the brain, and all of these are motor because you can think of it as like the decision to move is coming from your brain first, and it's descending down to your hand, for example. So these are descending pathways. Okay, so this is just a rule of thumb. Again, it's not purely motor or sensory. There's other things that can sort of come into play here, but this is how we like to think about it, at least for now. Okay, so ascending pathways, we have the main ones here. So we have, this is right here, the anterolateral fasciculus. So that's what it's called, but it basically, you guys are going to know it as the spinothalamic tract. So this is the spinothalamic tract here. You have the spinocerebellar, so your anterior spinocerebellar and the posterior spinocerebellar. You have your posterior funiculus, so this is the dorsal column. So these are all ascending pathways. Again, you guys know what the dorsal column does. It carries proprioceptive information. So it can be split into two, the gracile fasciculus and the cuneate fasciculus. And you guys already know what the difference between that is. Gracile fasciculus carries information from the upper limbs, and the cuneate fasciculus carries information from the lower limbs. Okay. This is just something that you have to know. So the dorsal column. Again, you have the spinocerebellar tract that's going to carry information from your extremities to the cerebellum, so that you can, have better motor planning, you can have better posturing. This is all part of your proprioceptive functions. Things like fine motor skills are associated with your spinocerebellar tracts. Spinothalamic obviously collects pain, temperature, and sensation from your entire body and carries it up in these ascending tracts. Okay. Now we have the descending pathways here. I don't want you to focus on these too much. Just focus on the corticospinal tract. So you have your anterior and your lateral corticospinal tracts. And we'll talk about the difference between those are in a minute. Okay. But again, all of these are going to make up the white matter of your spinal cord. Okay. Now, how do you tell the difference between different parts of the spinal cord? How do you tell the difference between a cross section of like a cervical section or a thoracic section? Okay, well, first of all, let's think about it this way. What part of your spinal cord is closest to your brain? That's cervical. That means that every single axon, every single nerve in your body eventually has to carry its information through the cervical region in order to reach the brain. Okay, that means that the cervical region is going to have a very, very pronounced white matter. There's going to be a lot of white matter in the cervical region because all of the nerves from the entire body are coming through or are passing through the cervical section. Okay, so the first thing we can say is that the ratio of white matter to gray matter is very high in the cervical region. Like, and as you go up, as you go superiorly, you're going to have a larger ratio or a higher ratio of white matter to gray matter. Okay. And by the way, this thing that we can see here, this large ratio, again, we mentioned that you can see in thoracic, and look at the difference between all of the white matter that you see here in the cervical region and all of the white matters that you see in the sacral region. So it's very, very small compared to the cervical section. That's because there's not a lot of tracts that are passing through the sacral section, except for maybe just a couple of neurons that are carrying information from your legs or your feet or whatever. Okay. Second thing that I want you to know is that take a look at this anterior gray horn. Okay. The lateral extensions of the anterior gray horns, this section here, just know that this section applies or supplies the distal appendicular muscles. So anywhere where we have limbs, like your arms or your legs, for example, you're going to see a lateral extension here of the anterior gray horn. So you see that here in the cervical section, that's because this is supplying the brachial plexus and all of the muscles of the arm. And you also see that here in the sacral section because it's supplying, and the lower lumbar section, that's because it's supplying a lot of the muscles of the legs and feet. Okay. And in comparison, take a look here at the anterior gray horn in the thoracic section. It's barely anything. It's a very sort of thin anterior gray horn. And it's because there's not that lateral extension to supply the distal appendices, all right, or appendicular muscles. um and yeah, and we call that thing, by the way, when we have this lateral extension of the anterior gray horn, we call that a cervical enlargement or a sacral enlargement. Okay, so if you take a look at the spinal cord, you will actually see a sort of enlargement or a sort of bump in the cervical region, and that's because of these anterior gray horn cells, these very large anterior gray horn cells. Okay. And the last thing that I want you to look at, the main difference, is this thing called the lateral horn. Now, the lateral horn, this is the thing that I mentioned about the intermediate zone. So the intermediate zone has this thing that's called the lateral horn. What I want you to know about the lateral horn is that the lateral horn is where all of your preganglionic sympathetic neurons are. Okay, so we know we have the sympathetic ganglia sort of in the thoracic section. All of these preganglionic neurons that are going to eventually go and synapse in the ganglion, in those sympathetic ganglions, are coming from the lateral horns. So you only see these in thoracic sections. You don't see these anywhere else. Okay, so if you look at something and you know that, and you see that it has like, you can take a look at the white matter to gray matter ratio. That's the first thing that you look at. And you take a look at the anterior gray horn cells and you see that it's a sort of a thin extension, you know, compared to some of the larger extensions that you see in the cervical regions. And you see this thing, the sort of outpouching that we call the lateral horn, then you know that you're in the thoracic region. Okay. But if you look at this, for example, and you see this very large, very wide anterior gray horn, and you see a whole lot of white matter, like a lot of white matter compared to the gray matter, you know that you're probably in the cervical section or cervical region. Okay. So again, what part of the spinal cord is this section taken from? So look at a couple of things. Look at the ratio of the white matter to the gray matter. Take a look at the anterior gray horn cells and take a look at any structures that you can see in the intermediate zone. So the answer, this is the thoracic spinal cord. This is the thoracic section. What are the characteristic features? You have a high white to gray ratio. Again, it's high, but not as high as the cervical region, but it's still fairly high. You see a lateral horn, and you see a thin anterior horn without those lateral extensions that we talked about that are going to supply your appendicular muscles. What type of neurons are present in the lateral horn? Again, that's your preganglionic sympathetic. Oh, sorry, guys, just give me another minute. All right, sorry about that, guys. Again, what were you saying? Yeah, so this is a thoracic spinal cord because we can see the white-gray ratio, the lateral horn, the thin anterior horn. And what type of neurons are present in the lateral horn? Those are your preganglionic sympathetic neurons that are going to go ahead probably after this and synapse in the spine, in the sympathetic ganglion, all right, or in the sympathetic chain. Okay, now we're going to move on to the gray matter. So we discussed the white matter. Now we're going to talk about the gray matter in the actual spinal cord. Now, there's a lot of confusion about this diagram because a lot of people don't really know what is meant for them to learn, or is what's meant for them to know. So I'm going to simplify it for you. Basically, this diagram is just combining two different ways that we have of classifying different parts of the gray matter in the spinal cord. This section is a way that people classify, that's called the Rexhead lamina. So you see here, this is why it's called lamina. Rexhead lamina is just a way to number the different parts of the spinal cord, and then those numbers are then associated with specific functions. And we have the nuclei way of classifying, which is just basically the specific nuclei, specific collection of cell bodies that we know in the gray matter of the spinal cord. So Rexhead lamina, this part of the diagram, forget about it. I don't think you're meant to know any of it, and frankly, it's a little too confusing to try to learn it on your own anyways. So this is just the main, this right here is just the parts that you want to know. And again, not all of the nuclei are in this diagram. There's more nuclei that is left out, but these are just the main ones that you have to know for the purposes of this block. All right, so first we have the substantia gelatinosa and the nucleus proprius, which we can sort of group into one collection, and both of these together is for sensation or is for sensory pathways. So specifically the spinothalamic tract, which we know is for pain temperature, or pain and temperature, is going to synapse in these specific nuclei. So the substantia gelatinosa and the nucleus proprius are both for sensation. Okay. The main difference is that the nucleus proprius also carries proprioception and vibration. Okay, whereas the substantia gelatinosa is pretty much purely for pain and temperature. The main difference also between the pain and temperature, although you don't have to know this, but the substantia gelatinosa is for slow pain, which is your C fibers, whereas the nucleus proprius is for sort of it's for like the delta fibers, or I guess the different sort of pain that you could experience. Okay, but both of these are is for sensation. The dorsal nucleus is also part of the spinocerebellar pathway, so this is for proprioception. Okay, so the dorsal nucleus, another name for it is the column of Clark or Clark's column. So you're actually going to see it more commonly referred to as Clark's column rather than dorsal nucleus. Okay, but just something that you have to know is that this is for proprioception. Now, the anterior medial lateral nucleus is the thing that I talked about before. This is for the lateral horn. So again, this is has all of your sympathetic preganglionic um, neurons, and then you have your motor neurons of the anterior horn. These are the main ones that you have to know from the gray matter. So there's not much to it. And again, all of these would coincide with specific segments of the Rexhead lamina. So, for example, substantia gelatinosa is lamina 2, for example, and nucleus proprius is 3 and 4. Okay, but again, you don't have to know. You shouldn't try to waste your time with the Rexhead lamina. It's not that important. Okay, all right. Now we're going to move on to the tracts of the spinal cord, and this is where I guess the bulk of this lecture is going to be spent. Okay, we're going to talk about the first tract, which is arguably the most important descending tract, which is your corticospinal tract. Okay, so it's the descending tract. We know that it's for movement. So corticospinal tract, you should know that it's just for movement. All right. So it originates, again, since it's descending tract, it's going to originate from the pyramidal neurons and the cortex from specific places: the primary motor cortex, the premotor cortex, and the primary sensory cortex. And again, primary motor cortex, that's because all of your actual movements are going to be controlled by the primary motor cortex. The premotor cortex, this is where you have motor planning, or where you're making the decisions of what movement you're trying to accomplish. And the primary sensory cortex is also going to lend a couple of fibers to the corticospinal tract as well. Okay, now once it's coming down from the corticospinal tract, it's going to descend or travel ipsilaterally through the posterior limb of the internal capsule and the cerebral peduncle. You should know that it's through the posterior limb. This is very important to know. And then they're going to decussate, or most of these fibers are going to decussate in the caudal medulla specifically, and then they're going to continue in the lateral and anterior corticospinal tracts in the spinal cord. Okay, this is why back here we said that we have a lateral corticospinal tract and an anterior corticospinal tract. Okay, so 90% of the fibers in the corticospinal tracts are going to continue as the lateral corticospinal tract, and 10% are going to continue as the anterior corticospinal tracts. Okay, and all of these fibers, eventually, they're going to synapse with the lower motor neurons in the anterior gray horn cells. Okay, so you have two fibers that you need, or it's one synapse and two fibers that you should remember that's going to make up your corticospinal tract. The first one, or the entire motor system, the first one is your corticospinal tract. That's your upper motor neurons. Those are your upper motor neurons coming from the brain. They're going to synapse in the anterior gray horn, and they're going to synapse with the lower motor neurons, and those are your actual peripheral nerves that are going to go and innervate a specific muscle. Okay, you should know that at rest, when you're not making any actual movements, you're not planning any movement, the upper motor neurons provide an inhibitory modulation to the lower motor neurons. Okay, so they're going to inhibit the lower motor neurons. That's why when we have an upper motor neuron lesion, you're going to see things like hyperspasticity or hyperreflexia or hypertonia. And that's because your lower motor neurons, you have disinhibition of these lower motor neurons. So they're going to be firing just completely on their own. And that's going to lead to increased tone, increased, hyperreflexia, all the things, all the classic signs that you see in upper motor neuron lesions. Okay. So this is your cortical. This is what you have to know about the cortical spinal tract. Okay. So let's say we have a lesion, let's say here in the midbrain. What part, or like okay, so this is the right midbrain. So the right midbrain, for example, if a lesion just completely destroying the right midbrain, what part of the body is going to be paralyzed? That's your left, so the left side of the body, because it decussates, right? Because it decussates at the level of the medulla. But if we have something distal to the medulla, so if we have a lesion like a spinal cord lesion down here, for example, then we're just going to see ipsilateral hemiparesis or ipsilateral paralysis because the decussation has already happened. Does that make sense? Okay, so it all has to do with where exactly you have these fibers crossing over. Okay, if it's proximal to it, you're going to have contralateral signs, and if it's distal to the decussation, you're going to have ipsilateral signs. All right. Okay. Perfect. And again, this is just a picture so that you can clearly be able to tell. So we already looked at this picture. So again, these fibers are going to come down. They're going to travel through the internal capsule right here. This is the internal capsule, the posterior limb specifically, through the cerebral peduncles, through the midbrain, and then they're going to decussate in the medulla. You can see here they decussated, yeah, in the medulla, or most of them decussated in the medulla, and then right here. Actually, I guess it's going to be a little distal to this. So this is not the best diagram. This is a better diagram to look at. Okay. And then they're going to decussate, and 90% of them are going to go to the lateral corticospinal tracts. 10% of them are going to stay in the interior corticospinal tracts. So they're not going to cross over. And again, they're coming down here, and then they're going to go, and let's say we have a spinal nerve exiting out of this specific section or the specific level, then it's going to come down in the lateral corticospinal tract. It's going to go ahead to the anterior gray horn, synapse there, and then it's going to exit out of the spinal nerve and go on and innervate specific muscle that it wants to move. Okay. Okay. What lesion associated with this finding? Let's rewind that. You guys see that? So this is the examiner here is trying to passively move this man's arm, and you can see it's a bit rigid. So this is an upper motor neuron lesion. Who knows what this finding specifically is called? This is the clasp knife spasticity. So this is a key word that you should know is associated with an upper motor neuron lesion. So what's the reason behind this finding? This is disinhibition of lower motor neurons due to a loss of descending upper motor neuron control. Again, we said that this provides inhibitory modulation to the lower motor neurons at rest. So if you have destruction or a lesion with the upper motor neurons or a problem with the upper motor neurons, it's going to lead to disinhibition. Okay, and what other findings can be seen with such lesions? Hypertonia and hyperreflexia are the main ones that you should know. Okay, what about fasciculations, guys? Fasciculations. If they said that somebody has fasciculations, that's a lower motor neuron. Okay, it's not upper motor neuron. Perfect. Moving on to the second tract that we're going to talk about. This is the DCML, or the dorsal column / medial lemniscus tract. So this is the first ascending tract we're going to talk about. Carries fine touch, vibration, and proprioception. This is the fasciculus gracilis and fasciculus cuneatus that we talked about before. So again, since this is ascending, it's going to it's going to enter the spinal cord through where exactly? The dorsal root. So the dorsal root ganglion is where the first order sensory neurons are. It's going to travel ipsilaterally in the dorsal column. So again, you have these neurons that are going to enter through the dorsal column. They're going to ascend ipsilaterally, so throughout the entire length of the spinal cord until they reach the medulla. Now, in the caudal medulla, you have the nuclei, the actual cell bodies where the first order neurons are going to synapse with the second order neurons. So these cell bodies are called the gracile nucleus and the cuneate nucleus. Okay, and again, each fasciculus is going to synapse with its corresponding nuclei. So the fasciculus gracilis, which is again carrying information from the lower body, is going to synapse in the gracile nucleus, and the fasciculus cuneatus is going to synapse in the cuneate nucleus. Okay, and that's where your second order neurons are. Now those neurons are going to also decussate in the medulla. So you have two crossing over of major tracts going on in the medulla: the corticospinal tract and the dorsal column. Both of them are going to synapse in the medulla. So again, they're going to decussate in the caudal medulla as internal arcuate fibers. So while they're decussating or while they're crossing over, those specific fibers that are crossing over are called the internal arcuate fibers, and then they're going to form the medial lemniscus. Okay, so the dorsal column is the pathway that's still in the spinal cord. Once it enters or after it decussates, is going to form the medial lemniscus. Okay, now those fibers, after they've crossed over here, they're going to ascend now. And again, so now they're carrying, at this point, they're carrying sensation from the contralateral body because they've already crossed over. And then they're going to synapse one last time or second time in the thalamus. Now, where exactly in the thalamus? That's your ventral posterior lateral nucleus of the thalamus, or the VPL. Okay, where they synapse with the third order neurons, they're going to project their neurons or their stimuli to the primary somatosensory cortex here. And that's basically going to tell our brain, hey, this is all the proprioceptive information about the contralateral body. Okay? So again, let's recap one more time. You have proprioceptors from the lower body. These sensations are going to be carried by these first order neurons. And again, these cell bodies are present in the dorsal root ganglion. They're going to enter through the dorsal root. They're going to ascend up ipsilaterally throughout the entire length of the spinal cord in the dorsal column. Okay. And then they're going to synapse in the gracile and the cuneate nucleus in the caudal medulla. Then they're going to cross over as the internal arcuate fasciculus or internal arcuate fibers. And then they're going to ascend up more through the pons and through the midbrain and through the internal capsule until they reach the ventral posterior lateral nucleus of the thalamus, where they're going to synapse again. And then those third order neurons are going to carry that information to the primary somatosensory cortex. Okay. And this is where these ascending pathways are right here. So the cuneate fasciculus and the gracile fasciculus. Okay. Now, this is all sensation from the body. So, inferior to your neck. What about all the sensation from your face? It's very similar. So you have here something called the principal sensory nucleus of cranial nerve 5. We know that cranial nerve 5 or the trigeminal nucleus is going to carry all that information, all that sensation from the face. All right, it's going to enter. And it's also going to travel up to the thalamus, but the difference here, instead of synapsing in the ventral posterior lateral nucleus, is going to synapse in the ventral posterior medial nucleus of the thalamus. Okay, so VPL for the body, VPM for the face. Okay, and then it's going to also project those fibers to the primary somatosensory cortex. Okay. Now, moving on to the spinothalamic tract. And again, this is an ascending tract. So same thing. So it's ascending. This is its sensation. We know that it's carrying pain and temperature. It's going to enter the spinal cord through the dorsal column, which means that these first order neurons are also in the dorsal root ganglion. Okay, but the main difference here is that these cells are actually, or sorry, this tract, these fibers are going to synapse as soon as they hit the spinal cord. Okay, so they're not gonna, or sorry, they're gonna decussate as soon as they hit the spinal cord. They're not gonna travel up to the medulla and then cross over there. So they're gonna cross over actually just like one or two levels after they've entered, or one or two levels superior to where they entered the spinal cord. They're going to cross over. First, they're going to synapse, and then they're going to cross over, and then they're going to continue up to the brainstem. So we said again that they're originating from first order neurons in the dorsal root ganglia. They carry pain and temperature and crude touch. And again, they enter the spinal cord and then they ascend one or two levels. So this is not descend, it's just ascend. Ascend one or two levels in Lissauer tract. So this is the name of the tract that it's basically just the ascension of these spinothalamic tracts before they decussate. And then they're going to synapse in the dorsal horn. Specifically, they're going to synapse in the substantia gelatinosa and the nucleus proprius, which we talked about previously. Those are the collections of cell bodies or the nuclei that's in your gray matter in the spinal cord. Okay, so again, just to summarize, you have these sensations, these stimulus that's coming, which is pain and temperature. It's going to enter the spinal cord through the dorsal root ganglia. Okay, and it's not gonna. This is, I guess, a bit of a confusing diagram, but it's not going to cross over immediately. It's going to cross over just one or two levels above where it's entered. And again, that sort of those fibers that are sending up just those one or two levels is called Lissauer tract. And then they're going to synapse in the dorsal horn, specifically the substantia gelatinosa and the nucleus proprius, and then they're going to cross over. They're going to cross over here, and when they cross over, we call that the anterior, the anterior commissure. Okay, which we'll talk about in a second. Okay, so again, they synapse in the dorsal horn, and then the second order neurons, they decussate in the anterior white commissure within one or two spinal levels of where they enter. Okay, so again, they enter, they synapse, and then they cross over in the anterior white commissure. And then they cross over and then they ascend contralaterally in the anterolateral column as the spinothalamic tract. And then they synapse again in the ventral posterior lateral nucleus of the thalamus, where the third order neurons project, again, same thing, to the primary somatosensory cortex. Okay, so that's the main difference here. And again, this is what we talked about here, the nucleus proprius and the substantia gelatinosa. This is where those fibers are synapsing. And these are your spinothalamic. This is your spinothalamic tract, all of that here. The anterior lateral fasciculus. Okay. Some people call the spinothalamic tract the anterior lateral fasciculus or ALS for short. Okay. But for our case, you could just remember it as the spinothalamic tract. Okay. And again, this is what it looks like. So dorsal root ganglion, dorsal horn, synapse, crossover, ascend contralaterally until it reaches the ventral posterior lateral nucleus of the thalamus, and then it's going to go to the primary somatosensory cortex. Okay. All right. So what's the diagnosis here? Well, there's a spinal cord lesions affecting the entire right side of the spinal cord. So this is a Brown-Séquard syndrome, okay, which is another word for saying this is a complete hemisection of the spinal cord. What's the pattern of loss of motor function? Again, this is at the level of the spinal cord. And where did we say the corticospinal tract is going to decussate or it's going to cross over? That would be in the medulla. And what do we say? If it's proximal to the medulla, it's going to be a contralateral paralysis. But if it's distal to the medulla or distal to the point of decussation, then it's going to be ipsilateral. Okay, so again, these are ipsilateral upper motor neuron signs below the level of the lesion and ipsilateral lower motor neuron signs at the level of the lesion. And obviously that makes sense. So imagine here you have your corticospinal tracts would be like right here, for example. So anything below the level of this lesion would show upper motor neuron signs, but also you have damage to the lower motor neurons at the specific region. So for the spinal nerves that are exiting at the specific region, those muscles are going to have lower motor neuron signs, and that's because you have degeneration, I guess, of these specific neurons here. Okay, but just know that it's ipsilateral for motor loss, and that's because it's distal to the decussation. Okay, now what's the pattern of loss of sensation? And this is general. Right now we're talking about both tracks. Okay, so ipsilateral loss of proprioception and vibration and contralateral loss of pain and temperature below the lesion. Let's pause right here. All right, does this make sense so far? Again, we said that the dorsal column medial meniscus also decussates or also crosses over in the medulla. All right, so distal to that, you would have ipsilateral symptoms, so ipsilateral loss of proprioception, but the spinothalamic tract crosses over immediately or crosses over in the spinal cord itself, which means that we're going to have contralateral loss of pain and temperature below the level of this lesion and loss of all sensation at the level of this lesion. Obviously, that makes sense, and that's because that's exactly where the spinal nerve is going to come out. Okay. And this is a picture so that you can actually tell what's going on. So say we have this is the level of the lesion right here. It's in the right side of the body, or yeah, right side of the body. Then contralateral to it, you're gonna have impaired pain, temperature, crude touch. Because imagine for a second you have like the spinothalamic tract, or you have a nerve carrying information from this leg. It's gonna enter the spinal cord, and then it's going to continue up, and then it's going to cross over. Okay, so if it's crossing over and you have a lesion here, then it's going to damage or it's going to have contralateral symptoms for the spinothalamic tract. Okay, whereas for the corticospinal tracts and for the dorsal column and the medial lemniscus, it's going to be ipsilateral. Okay, I hope that makes sense. And now we're gonna finish off talking about the lesions. So we mentioned already Brown-Séquard, which is a complete hemisection. We have poliomyelitis, which you're not gonna get too many questions on poliomyelitis, just because polio in and of itself is eradicated in the US at this point. So you barely would get questions on it. But just so you know, this is destruction of the anterior horn cells. So because of that, it's going to be primarily lower motor neuron signs, not upper motor neuron signs. But the main difference with poliomyelitis is that they're asymmetrical. So this is asymmetrical weakness. So you'll see, for example, that the patient's right side is a lot weaker than the patient's left side. Okay, and that's poliomyelitis. And again, these are lower motor neuron signs. Okay, spinal muscular atrophy is a congenital. Sorry about that, guys. It's kind of a tough time to try to do a PAL. Anyways, let's keep going. Um, Again, spinal muscular atrophy. This is a congenital degeneration of the anterior horns. Okay, and this is symmetrical. So this is different than poliomyelitis because it's symmetrical degeneration. And since it's congenital, you're going to see that in babies. And the classic, the buzzword that you're going to see with spinal muscular atrophy is a floppy baby. So I think it should be, yeah, floppy baby. Okay. And the degeneration is because of a gene mutation. So that's SMN1, which encodes for survival motor nucleon motor neuron protein, and it leads to defective SNRMP. So this is small nucleic ribonucleoproteins. So this has to do with mRNA processing and intron splicing and everything like that, which leads to lower motor neuron apoptosis, the mutation, I mean. Okay. So this is also called Werdnig-Hoffmann disease. All right. And these are only lower motor neuron signs because again, there's only degeneration, congenital degeneration in the anterior grain horn cells. Okay, now this is different from ALS or amyotrophic lateral sclerosis because ALS is combined upper motor neuron and lower motor neuron. And its familiar form, which is less common, it might be linked to SOD1 mutations, which encodes superoxide dismutase 1. Okay, and this is another name for Lou Gehrig disease. All right. So the lower motor neuron signs would be things like flaccid limb weakness, fasciculations, atrophy, bulbar palsy, there's arthria, dysphagia, tongue atrophy. And the upper motor neuron signs are things like spastic limb weakness, hyperreflexia. So you'll see both. Okay, and you won't see any bowel or bladder deficits because these lesions are purely in the corticospinal tracts and the anterior gray horn cells. All right, and this is fatal because of respiratory failure, because you have loss of innervation of the inspiratory muscles, like the diaphragm, for example. All right, and the treatment is something called riluzole. Riluzole. All right, and we have tabes dorsalis, which is one of the manifestations of tertiary syphilis, which is caused by Treponema pallidum. All right, and this is, as you can see here, it targets just the dorsal column and the dorsal ganglia or the dorsal roots specifically. So you're going to see Romberg sign, positive Romberg sign, which you guys already should know what Romberg sign is. It basically, like when the patient is asked to close their eyes and stand still, they're not able to stand still. That's because the proprioceptive function is lost or is weakened, and absent deep tendon reflexes. All right, and that's again because of the loss of proprioceptive sensation. All right. So this is purely dorsal column and like it's purely sensory. All right. Associated with shooting pain, Argyll-Robertson pupils, which is something also associated with syphilis. You need to know it right now, and Charcot's joints, which is also seen in diabetes mellitus. All right. Let's answer a question. A 3-month-old infant with severe hypotonia, poor head control, weak cry, and difficulty feeding. Physical exam shows tongue fasciculations, absent deep tendon reflexes, and symmetrical muscle weakness, but sensation is intact. What's the diagnosis? So this is spinal muscular atrophy. Now, the reason it isn't ALS is two main things. First of all, they didn't mention any upper motor neuron signs, so just the fasciculations and the absent deep tendon reflexes and the severe hypotonia. So these are all lower motor neuron signs. The second thing, this is because it's an infant. So a 3-month-old infant is much more likely to have a congenital cause than something that could be, could manifest in later years or in adulthood or even in late adulthood. Okay, so this is spinal muscular atrophy. It's associated with SMN1 mutation, which has to do with mRNA processing. Okay. 75-year-old patient with cervical hyperextension injury after a fall now presents with weakness in the upper extremities greater than the lower extremities and variable sensory loss. What's the diagnosis? So this is central cord syndrome. Okay, so central cord syndrome, when we have sort of a hyperextension injury, it's going to damage this sort of central part of the spinal cord. So you can see here, you can try to think of it this way. What tracts are running here specifically? First of all, we have loss of motor function here because you might hit either the anterior. It depends on how large, I guess, surface area of the injury is, but you might hit either the corticospinal tracts or you could hit the anterior grain horn. But the main thing that I want you also to notice is the fact that it's weakness in the upper extremities greater than in the lower extremities. All right, and that's because all the sort of sensations or all of the sort of the neurons that have to do with the upper extremities are located more medial compared to the ones that occupy or I guess innervate the lower extremities. Okay, so that's why when you have a cervical hyperextension injury, you're gonna much more likely be affecting the upper extremities. All right. Okay, and this is just something you have to memorize. That has to do with a cervical hyperextension. So you see a patient, for example, after a severe acceleration deceleration injury, like in a road traffic incident, they're presenting a couple months later with a central cord syndrome. Okay. All right. A vegan would likely have which of the following spinal cord lesions? A vegan. So think about what sort of nutrients a vegan would be deprived from. The answer is A. Okay. And what would A be? So this is subacute combined degeneration, so SCD. All right. What's B? So this could be either syringomyelia or it could be like a milder form of central cord syndrome. And C, what's C? So this is C would be like an injury to anterior spinal arteries, for example, or the vertebral arteries. Okay. All right, so subacute combined degeneration. This is demyelination of spinocerebellar tract. So this is not degeneration of the neurons. This is demyelination of the spinocerebellar tracts, the lateral corticospinal tracts, and the dorsal columns. So SCD. This is the mnemonic. So S for spinocerebellar, C for corticospinal. This is the corticospinal tract, and D for the dorsal columns. Because of a vitamin B12 deficiency. And vitamin B12 is found in a lot of animal products. That's why vegans, usually it's going to manifest like for a vegan who's been a vegan who hasn't had any animal products for years and years. And they're going to present with, because of these tracts that are affected, ataxic gait, paresthesias, an impaired position vibration sense because of a positive Romberg sign. Sorry, this is supposed to be, you're not supposed to see this yet, but that's okay. And an anterior spinal artery occlusion. Again, we know that the anterior spinal artery basically supplies the anterior part or anterior section of the spinal cord. So if you have an occlusion in the anterior spinal artery, which is this thing right here, it's going to affect the entire anterior area. So that's your anterior gray horn cells. So you're going to have lower motor neuron signs at the level of the lesions, and also the corticospinal tracts and all the other tracts in the anterior section. So upper motor neuron signs below the lesion, and loss of pain and temperature also below the lesion because they're affected. The spinothalamic tracts can be affected too. Okay, but you'll see here the dorsal column is spared. A 50-year-old patient with progressive gait instability and lightning-like shooting pains in the leg. Examination shows loss of vibration proprioception in lower extremities, positive Romberg sign, and absent patellar reflexes. The patient also reports episodic urinary incontinence and visual changes. What's the diagnosis? Tabes dorsalis. Okay, so the lightning-like shooting pains in the leg is a buzzword for tabes dorsalis. Also the positive Romberg sign, and also the visual changes. Okay, again, we have this thing that's called the Argyll-Robertson pupils in tabes dorsalis because of the tertiary syphilis that you'll see here. And all of that points to tabes dorsalis. Okay. Okay, so again, this is just a summary of the lesions that we talked about. We have, first of all, anterior cord syndrome because of occlusion of the anterior spinal artery. And again, you could just like, if you know the spinal cord well, if you're able to look at a section and know generally where all the tracts are going or where all the tracts are, then you'll know immediately where, what manifestations you would have with any lesion. Okay, so just know that the pyramidal tracts are all like sort of in the intermediate zone, closer to the posterior section or the dorsal horn. The spinocerebellar tracts are along the edge of the spinal cord, along the edges of the white matter, specifically. Anterior white commissure is right here. The anterior horn, whatever, lateral horn, you guys got it. Okay, so central cord syndrome with hyperextension injury or syringomyelia, which we're also going to talk about in a minute. Occlusion of the posterior spinal artery would lead to these following changes. Now, diseases of the anterior horn are things like ALS. So you'll see the upper motor, the corticospinal tracts and the anterior gray horn cells. So these are both, this is a combined upper motor neuron and lower motor neuron. And SMA or poliomyelitis is just anterior gray horn cells. What's the main difference? SMA is congenital and it's symmetrical weakness. Poliomyelitis is not congenital and it's asymmetrical weakness. Brown-Séquard, it's complete hemisection. Tabes dorsalis because of syphilis is the dorsal columns and the spinal or the dorsal roots. Friedreich ataxia, we don't have to talk about it right now, but also SCD or subacute combined degeneration. Again, spinocerebellar tracts, corticospinal tracts, and the dorsal column, and this is because of a B12 deficiency. Okay. All right. Moving on to brainstem and brainstem lesions. Okay, first of all, we're going to recap and sort of review all of the cranial nerves, 1 through 12. So 1 is olfactory, so this is for smell only, and it's purely sensory. 2 is optic, so it's also sensory. 3, the oculomotor, it's purely motor. So there is also a parasympathetic function of the oculomotor nerve, like the accommodation reflex, but it's mostly for extraocular movements, most of the extraocular muscles. Trochlear is also for eye movement, but it's specifically for the superior oblique, so it's also pure motor. Trigeminal is for both, so there's a sensory function because it's going to carry sensation from the entire face, and it also supplies the muscles of mastication, so the jaw muscles. So it's both motor and sensory. And for somatosensation from the anterior 2/3 of the tongue. Okay. The abducens nerve or cranial nerve 6 is also for an extraocular muscle, which is the lateral rectus muscle, so it's motor. Facial nerve is also both, and that's because it's responsible for all of the facial muscles, and it also carries taste from the anterior 2/3 of the tongue, and it has a parasympathetic section for salivation and lacrimation. Okay, so salivation specifically from the submandibular and the sublingual glands. All right, you have the parotid glands, which is carried by the glossopharyngeal. Vestibulo-ocular, which is cranial nerve 8, is for hearing and balance, so it's sensory. Glossopharyngeal, as we mentioned, parotid gland, so it's parasympathetic for salivation from specifically the parotid gland. Also carries taste and sensation from the posterior third of the tongue, and swallowing and carotid body and sinus chemo and baroreceptors, and elevation of the pharynx larynx. Vagus is for taste from the supraglottic region, swallowing, soft palate elevations, uvula, talking, cough reflex, and very importantly, parasympathetic to the thoraco-abdominal viscera, and monitoring the aortic arch chemo and baroreceptors. So things like tachycardia, bradycardia are all, and things like gut mobility, or sorry, stomach, gastroparesis or things like that are affected with the vagus nerve. Accessory nerve carries innervation for 2 muscles, which is the sternocleidomastoid and the trapezius muscles for head turning and shoulder shrugging. And finally, the hypoglossal nerve, which is pure motor, just for the tongue movements. Okay, and this is a picture of the brainstem. This is where all of the nerves come out from. So, again, this is the optic chiasm. This is the optic nerve. The olfactory is actually a little bit higher. You're not going to be able to see the olfactory here. This is the oculomotor. Oh, you should know, by the way, you guys should remember this by now, but your rule of 4s is very important when we're looking at the brainstem. We'll talk about it in a minute, but just keep that in the back of your mind when we go through the rest of these slides. All right, so we have the oculomotor nerve here, the trochlear nerve, which is going to come out the posterior midbrain, but it's going to wrap around and make its way anteriorly. You have your trigeminal nerve here exiting from the pons. Try to think of it like this. There's 12 cranial nerves. You have the first 4 exiting above the pons, 4 exiting at the level of the pons, and 4 exiting below the level of the pons. So the 4 exiting above are 1 and 2, which, olfactory and optic, and 3 and 4, which are oculomotor and trochlear. Now the 4 at the pons are 5, 6, 7, and 8, so trigeminal, abducens, facial, and vestibulocochlear, sorry. And then the 4 below the level of the pons are the glossopharyngeal nerve, the vagus nerve, the accessory nerve, and finally the hypoglossal nerve. Okay, and this is your pons. These are your pyramids, which are your corticospinal tract. These are the olives, which have the inferior olivary nucleus. This is the pyramidal decussation. This is where the corticospinal tracts are going to decussate, which we mentioned before. And then the anterior median fissure. Okay. So we're going to review very quickly. We're not going to spend too much time on it, just the certain parts of the brainstem. So starting at the medulla, okay, we see here the decussation. So right now we're at the level of the decussation of the pyramid. So if we take a cross section right here at this section, this is where we are right here. So you have the decussation of the pyramids here. You have the spinothalamic tract. Always remember the motor pathways are more medial. The sensory pathways are more lateral. Okay, so the decussation of the pyramids, you'll see it's purely it's motor, so it's in the middle. It's right in the middle. Nucleus gracilis and nucleus cuneatus, which we mentioned carries the second order neurons for the dorsal column. You need to charge my MacBook soon. Again, these are all in the caudal medulla. We have the spinal tract and the spinal nucleus and the spinocerebellar tract. So all of these are ascending pathways. So that's why we mentioned that they're lateral. And again, this is a cross section of the medulla. Now here, these are the ones that you mainly need to remember. These two. Um, so here you have the decussation of the dorsal column or the medial lemniscus. So you have the nucleus gracilis here. This is where the second order neurons, or this is where the first order neurons are synapsing with the second order neurons, and then they're going to decussate. This is the reticular formation that we're beginning to see a little bit of the inferior olivary nucleus here. Again, we're starting to move up a little bit more superiorly. All of the sensory pathways are still lateral. So the spinal tract from the trigeminal nerve, the spinal nucleus from the trigeminal nerve, the nucleus ambiguous and everything like that, that's still going to be lateral. The pyramids here are medial. And again, so the medial meniscus here. So here at this point, we've had the decussation of both. We've seen the decussation of both the pyramids, the corticospinal tract, and the medial meniscus or the dorsal column. So here, always in the medial part of the brainstem, we have the pyramids. We have the medial meniscus carrying proprioceptive function, and we have our motor nuclei, our pure motor nuclei. So in this case, since we're looking at the medulla, we can see the hypoglossal nucleus medially. Okay. And right lateral to it, we see the dorsal motor nucleus of cranial nerve 10 or the vagus nerve and the solitary nucleus. This is where the vagus nerve would be exiting from. The reticular formation here, responsible for consciousness. And then within it, we have the nucleus ambiguous. Okay. The lateral spinothalamic tracts. So these are again lateral. The inferior cerebellar peduncles, all the, we can see all of those here. And the inferior vestibular nucleus that supplies, innervation, or I guess, yeah, it produces the nerves of the vestibulocochlear nerves. Okay. And the inferior olivary nucleus here. This is what tells us that we're in the medulla. Okay. Now, moving on to the pons, again, we keep our rule in mind. All of the medial structures, all of the motor structures are medial. All of the sensory structures are lateral. So all the corticospinal and corticobulbar tracts here are medial. The nucleus of the abducens nerve and the motor nucleus of the facial nerve are also medial. We also have here the MLF, the medial longitudinal fasciculus. So all of these structures are midline. And again, we have here the facial colliculus because of the wrapping around. So the facial nerve is going to wrap around the abducens nucleus here. That's going to produce the facial colliculus. And again, we mentioned here anteriorly in the midline, we have the corticospinal and the corticobulbar or the corticonuclear fibers. All right, and laterally we see the vestibular nuclei. We see the superior cerebellar peduncles. We see, all these different structures that are going to be more sensory, like the spinal tract and nucleus of the trigeminal nerve. Okay. And as we move up, we see the trapezoid body, which we mentioned before has to do with the vestibulocochlear system. We see the medial meniscus. Okay. Medial meniscus is also present here. And then we see obviously these the trigeminal nerve with the motor nucleus and the sensory nucleus. This is like cranial pons. All right. And again, we have to know all this. The main thing that I want you guys to know when we're talking about brainstem lesions is just remember the four pure motor nuclei that are in the middle. So that's your oculomotor, that's your abducens. So 3, 4, 6, and 12. So oculomotor, trochlear, abducens, and hypoglossal. If you know what signs to look for in each one of those cranial nerves when they're damaged, then you'll know exactly where you are at which level of the brainstem. All right. If you see tongue deviation, for example, you'll know that that's the hypoglossal nucleus, so you'll know you're at the level of the medulla. All right. If you see a pupil that's down and out, for example, that's midbrain, that's oculomotor. All right. And like diplopia, for example, that's trochlear. All right, so just keep all those in mind. Again, now we're going a little bit higher up. We're reaching the midbrain. So the same structures that we talked about here, the substantia nigra. This is the crus cerebri, which has all of the corticospinal and corticonuclear fibers within it. The substantia nigra are where all of the dopaminergic neurons of the basal ganglia are. And again, we have here all of the lemniscuses. So the trigeminal lemniscus, the medial lemniscus, and the lateral lemniscus here. You have here your Edinger-Westphal, I think it's right here. Yeah, the Edinger-Westphal nucleus. And again, this is the nucleus of the trochlear nerve. You'll see because the trochlear nerve is exiting out the posterior side of the midbrain and it's wrapping its way around, anteriorly. Here you have your inferior colliculus, and then here at the higher level, you have the superior colliculus, you have the cerebral aqueduct. Again, this is right here we're at the level of the oculomotor nerve. So this is the nucleus of the oculomotor nerve. It's in the midline, and then the MLF, the medial longitudinal fasciculus. The red nucleus here, which is responsible for posturing, okay, and the decussation. Again, you don't have to know the rubrospinal tracts. Okay, this is just the main thing again that I want you to know are those four main nerves, four main nuclei: the oculomotor, trochlear, abducens, and hypoglossal. Okay, now we're talking about strokes and specifically the circle of Willis. All right, so the circle of Willis, if we're going to simplify it, is just a collection of anastomoses between a anterior circulation and a posterior circulation. Now, the anterior circulation is coming mainly from the internal carotid artery. All right, so imagine this is an inferior view, by the way. We're looking inferiorly up at the brain and all of the vessels. Okay, and imagine we sort of take a section and we go obliquely like this. Anything anterior to this line would be the anterior circulation. So this is the ICA, and anything posterior would be the posterior circulation. Now, the circle of Willis is just an anastomosis between those two circulations. Okay, so again, you have the internal carotid artery. It's going to form from the common carotid artery. It's going to come upwards, and then it's going to give off the MCA, the middle cerebral artery, and also a couple of anastomoses. So the anterior communicating the ACOM here in the anterior cerebral artery, and then the PCOM to connect with the posterior circulation. Okay, so main thing that I want you to know is when we're talking about the brainstem, which levels of the brainstem are supplied by which arteries. So if we're talking about lateral medulla would be here, or sorry, like the medulla in general would be here. So lateral medulla would be supplied by the pica, or the posterior inferior cerebellar artery. Medial medulla would be supplied by the vertebral arteries, or this right here, this branch of the vertebral arteries, which is known as the anterior spinal artery. Okay, lateral pons would be supplied by the ICA, or the anterior inferior cerebellar artery, and then it's going to continue up. So the medial pons would be the basilar artery, or these branches, these pontine or paramedium branches of the basilar artery. Lateral midbrain would be supplied by the posterior cerebellar artery. The superior cerebellar artery would also supply some parts of it, but it's mostly for the cerebellum. And then the medial midbrain is supplied by also the posterior cerebral artery or the basilar artery. Okay, and then you have your anastomoses right up here. Okay, so again, to localize brainstem strokes, you remember the 4 rules of 4. First one is the 4 nuclei that are below the pons. So that's 9 to 12 in the medulla. 4 are in the pons and 4 are above the pons. That's the first one. 4 factors of 12, except 1 and 2 are purely motor. So that's 3, 4, 6, and 12. Those are the ones that I talked about. 4 structures beginning with M are located in the midline. So motor nuclei, like these ones that we talked about, are always in the midline. Motor pathways like corticospinal tracts, medial lemniscus, so the proprioception and vibration, and medial longitudinal fasciculus. So the M is for middle, and the S is for like to the side, or I guess lateral. So that's spinocerebellar, spinothalamic, spinal sensory, and the sympathetic pathway. Okay, so those are just things that you have to know. All right, starting with the Wallenberg syndrome, or the lateral medullary syndrome. All right, so Wallenberg syndrome, again, what did we say? This would be a occlusion of which artery? This would be occlusion of PICA, posterior inferior cerebellar artery. That's because it supplies the lateral medulla. Now, think back for a second and try to remember the structures that were in the lateral medulla. Well, we know we have the spinothalamic and the spinal trigeminal tracts, we know that we have the sympathetic pathway, and we know we have the vestibular nuclei, right, in the medulla. So all of the symptoms are going to be related to those. Okay, this is a very good mnemonic that I want you guys to try to remember. Don't pick a lame horse that can't eat. So don't pica or pica for posterior inferior cerebellar artery, lame for lateral medullary syndrome, hoarseness, that's because you're affecting the like the nucleus ambiguous, which is going to supply the cranial nerves, like the cranial nerves 9 and 10, the glossopharyngeal and the vagus nerves that are going to supply the voice or the vocal cords that can't eat, dysphagia because of the same reason. All right. And the symptoms are going to be dysphagia, hoarseness, decreased gag reflex, and hiccups. All of that is because of the, uh, because the nucleus ambiguous is affected. Again, with vestibular nuclei, so you're going to see vomiting, vertigo, and nystagmus. The spinothalamic tract and the trigeminal nucleus. So you're going to see contralateral loss of pain and temperature sensation, and ipsilateral loss of sensation from the face. Okay. So it's going to be, those two are going to be opposite. So it's going to be, take a look here. So here, so this is the ipsilateral face. This is the contralateral body. That's because, again, we mentioned that the spinothalamic tract is going to decussate way down in the spinal cord. So if you have a lesion proximal to it, it's going to be contralateral. Whereas the spinal trigeminal doesn't decussate at that level. All right. And again, you have also the sympathetic fibers in the lateral medulla. So that's going to lead to an ipsilateral Horner syndrome. And because the inferior cerebellar peduncle is also affected, you're going to see ataxia and dysmetria and other cerebellar symptoms. Okay. So again, this is Wallenberg syndrome. This is the area that's affected with pica. And this is just so that you guys can come back to this and try to remember which structures specifically are in the lateral medulla. Okay, so again, the hypoglossal, for example, wouldn't be affected because it's in the medial medulla, nor would the corticospinal tract or the MLF or the medial lemniscus. All right. Okay, now moving on to the medial medulla. Again, it's all about knowing what is in the medial side of the medulla or the brainstem in general, and what's in the lateral side of the brainstem. So since we're talking about the medulla specifically and medial medulla, the main thing we're going to look for is the hypoglossal involvement. All right, so you're going to see ipsilateral hypoglossal dysfunction. So the tongue would deviate ipsilaterally. All right, so if you ask the patient to stick out their tongue would deviate to the right. You know that that's a right medial medullary syndrome. Okay, so what's affected? Again, the midline structure, so the corticospinal tract, you're going to see contralateral paralysis, the medial lemniscus, which means decreased contralateral proprioception, and the hypoglossal nerve, so ipsilateral tongue deviation. Okay, and again, so this is the anterior spinal artery or the vertebral arteries, but it's most commonly seen with the anterior spinal arteries, as you can see here. So these are the main ones. These are the main structures that are going to be affected. Okay. All right. Now, one thing that tends to confuse a lot of people, me included, is what deviates to what side. Does something deviate ipsilaterally or contralaterally if its nuclei or if its nucleus is involved. So with cranial nerve 5, which is trigeminal motor lesion, the jaw would deviate toward the side of lesion due to unopposed force from the opposite pterygoid muscle. With cranial nerve 10 or vagus nerve involvement, the uvula would deviate away from the side of the lesion. And again, with the accessory nerve lesion, you have a weakness turning your head away from the side of the lesion. So you're not able to turn your head away from the side of the lesion, which means that your head's going to be turned toward the side of the lesion. Shoulder droop on the side of the lesion again. And with, again, like we mentioned, with the hypoglossal nerve injury, the tongue would deviate towards the side of the lesions. Okay? It's just something that you need to remember. All right. A 65-year-old patient with sudden onset contralateral spastic paralysis and loss of vibration and proprioception, along with ipsilateral inability to abduct the eye, so medial strabismus, and diplopia. Which of the following is affected? So contralateral spastic paralysis and loss of vibration and proprioception. So both the corticospinal tract and the medial lemniscus is affected. So we know that this is a midline structure, along with the ipsilateral ability to abduct the eye. What does that mean? We're unable to abduct the eye. We're unable to basically look, for example, my right eye is unable to look to the right, my left eye is unable to look to the left. What muscle is in control of that? It's the lateral rectus muscle. What supplies the lateral rectus muscles? That's the abducens nerve. So what nerve, what artery would this be? This would be J. Now, I know that maybe a couple of you said K, which is the basilar artery. Again, we know for sure that we're at the level of the pons because we have abducens, just because we have the abducens nerve involvement. So we know for sure that we're at the level of the pons. But the reason that the answer is J and not K is because with a basilar artery occlusion that would lead to locked-in syndrome. And locked-in syndrome is quadriplegia. And here we have contralateral spastic paralysis, which means that these are the paramedian branches of the basilar artery or the pontine branches of the basilar artery. Okay, so they're just gonna supply one side of the medial pontine structures. Okay, so again, if the entire basilar artery, you know, was involved, then we'd see locked-in syndrome. So the ocular nerve nuclei, so you have loss of horizontal but not vertical eye movements. This is locked-in syndrome, quadriplegia, and loss of voluntary facial, except blinking, mouth, and tongue movements. And the pons, the medulla, and the lower midbrain. If the reticular activating system or the reticular formation was spared, then consciousness would be preserved. Okay, so again, imagine the basilar artery would be supplying all of this, whereas the paramedian branches would just be supplying this section, for example, just the right section. All right. Okay, so it's very important to know the difference between a complete medial pontine lesion, which would lead to locked-in syndrome, and just a contralateral or a one-sided lesion. Okay. Now we move a little bit laterally, and we're going to talk about ICA syndrome, which is lateral pontine syndrome. It's the same thing. We know what's involved. We know what structures we have in the lateral side of the pons. Again, the vestibular nuclei, spinothalamic, spinal trigeminal, sympathetic, and the inner ear. So all of these so far, we know that this is similar to what you would see in the lateral medullary syndrome or the Wallenberg syndrome. The main difference is the facial nerve nuclei. So because you have involvement of the facial nerve, you're going to have paralysis of the face. So this is Bell's palsy. You would have complete Bell's palsy. This is lower motor neuron lesion versus what you would see in a more cortical stroke, like an upper motor neuron lesion. And because the facial nerve also supplies salivation and lacrimation. Also see decreased lacrimation, decreased salivation, and decreased taste from the anterior two-thirds of the tongue. Again, it's just about knowing where the nuclei are and where the nerves are exiting from. So facial nerve exiting from the lateral pons, so we know that that's going to be involved with an ICA syndrome. Okay, and what else could be involved? The cerebellar peduncles. So we have ataxia and dysmetria. You can have vertigo because of the vestibular. We already talked about the facial nucleus, ipsilateral loss of pain and temperature sensation from the face because of involvement of the spinal trigeminal tract, and spinothalamic tract is also affected, so loss of pain and temperature sensation from the contralateral body. Okay, again, this is ICA, so this is anterior inferior cerebellar artery. Okay, not cerebral artery, cerebellar artery. Okay. Again, you should know the difference between an upper motor neuron for the facial nucleus and a lower motor neuron. Okay. So first of all, you should know that the facial nucleus can be split into an upper division and a lower division. The upper division obviously would control the upper facial muscles, the ones that are from your eyes up. So the forehead muscles and the not the extraocular muscles, but the nerves that are, or sorry, the muscles that are supplying like the eyebrows, for example. All of that is in the upper division, and the lower division is all of the muscles supplying the lower part of your face. Okay. The main difference that I want you to know is that the upper division is contralaterally supplied. So it's it's bilaterally supplied. So it's supplied by both hemispheres, both the right and the left hemispheres supply both the upper divisions of both facial nuclei, which means if you have an upper motor neuron lesion, if you have, for example, here a lesion here, that would affect the contralateral lower division, but not the upper division because it's bilaterally supplied. Okay, does that make sense? So again, upper division of the facial nucleus, lower division of the facial nucleus. Lower division of the facial nucleus is only supplied by the contralateral cerebral cortex, but the upper division is supplied by the bilateral cortices. Both cortices are supplying the upper division, which means if you have an upper motor neuron lesion, let's say in the right side, like a right cortical stroke, then you would see weakness of the left lower face, but not the left upper face because it's bilaterally supplied by both the right and the left cortex. Okay. Whereas if you have a lower motor neuron lesion, like either at the actual facial nucleus, which we can see again in the lateral Pontine syndrome, or Bell's palsy because of the peripheral nerve injury, then it wouldn't matter. You would just see both. You would see weakness of both the upper part of the face and the lower part of the face. All right. Does that make sense? This is a very good diagram for you guys to study. So again, one last time, upper division bilaterally supplied, lower division contralaterally supplied. So you have upper motor neuron lesion, you have weakness in the contralateral lower face. Okay, but not in the lower contralateral upper face because it's bilaterally supplied. Okay, let's move on. We're moving on right now to the midbrain, and there's just two main syndromes that you have to know. And all you have to know is that all you should remember is that the oculomotor and the trochlear nerve are in the midbrain. Okay. And just know the difference between these two. So Weber syndrome is caused by a lesion in the medial cerebral peduncle in the midbrain. And again, we said the cerebral peduncle carries all of the corticospinal and corticonuclear fibers. So you have contralateral hemiplegia of the lower face. So again, because this is an upper motor neuron, these are corticonuclear tracts, and an oculomotor nerve palsy. Okay, but that's because the oculomotor nerve is coming out of the midbrain. Whereas Benedict syndrome is caused by a lesion in the tegmentum of the brain. It causes contralateral tremor and ataxia because of the involvement of the red nucleus, and also an oculomotor nerve palsy. So you guys see the similarities here. Just know, if you know that there's an oculomotor nerve palsy, then you know for sure you're at the level of the midbrain. Okay. And again, I'm not gonna talk about too much like what what oculomotor nerve palsy would look like, because you guys should know by now it controls all of your extraocular muscles. It also controls things like accommodation and the pupillary light reflex. But the buzzword that I want you guys to remember, if there's a pupil that's down and out, if it's down and out, that's pointing at an oculomotor nerve palsy. Okay. Okay. Now let's move on to your following lecture, which is the peripheral nerve injuries. Okay, to be honest with you, this lecture is purely like it's a lot of memorization. So I'm just going to include these two tables that I got from your lectures. But this lecture, inshallah, is very, very, very easy. You just have to go through it maybe once or twice and just try to really, really memorize all the differences, and you should be good. So we're going to move through it pretty quickly. There's not much to explain. So the axillary nerve, which is coming out of C5, C6, we know that it innervates the deltoid. This is the main thing, the deltoid. So the clinical sign with an axillary nerve palsy would be loss of abduction, because that's what your deltoids are in charge of, abduction of the arm. Okay. Musculocutaneous, it supplies the flexors of the arm, specifically the biceps brachii. So again, it's going to be weakness of flexion and supination in the elbow. So you're unable to flex the elbow and unable to supinate or have supination of the elbow. Radial supplies the extensors of the arm and the forearm, things like the triceps, for example, or all of this, like the flexor, the extensor digitorums. So it's going to be wrist drop because you're unable to extend the wrist. You're going to have wrist drop. And depending if it's if it's more proximal radial lesion, then you're also unable to extend the arm at the elbow, which is the job of the triceps muscle. Then we have the median nerve, which supplies the flexors of the forearm, and specifically the thenars and the lumbricals. So you're going to have APAN because you have loss of thumb opposition. So just remember just remember APAN. All right. Ulnar, you're going to have claw hand. So it's going to look like this, claw hand. And that's because you have clawing digits of 4 and 5. That's because the fingers, the 4 and 5th digits are supplied by the ulnar nerve. The long thoracic supplies the serratus anterior, which is going to cause a winged scapula. Okay, so when you ask the patient to put their arms up against the wall, you can see one scapula is like winged. It looks lower than the other. That's because of involvement of the long thoracic. And the suprascapular is for the supraspinatus. So this is a problem with the initiation of abduction. So we said abduction is under the control of the deltoid muscle, but initiation of abduction, or specifically like the first 15 degrees of abduction, is under the control of supraspinatus. So if you have a suprascapular nerve palsy, that's the main problem that you're going to see. Okay. Now for the lower limbs, if you have a femoral nerve, so the femoral nerve supplies all of the muscles and skin of the anterior thigh. So that controls things like knee extension. So you're going to have loss of knee extension, obviously. Obturator is the medial thigh. So you're going to have loss of thigh adduction. Okay. Tibial is all the muscles of the posterior thigh, things like the hamstrings, for example. Or sorry, no, not the hamstrings. This is posterior thigh and the leg and the plantar foot. So this would be the sciatic nerve that's actually responsible for the hamstrings. But the tibial nerve would, you would have things like loss of plantar flexion and everted foot, whereas the common fibular, you would have an inverted foot, okay, and a foot drop. Foot drop would be would mean loss of dorsiflexion. Okay, so this is if this is a foot, this would be dorsiflexion, this would be plantar flexion. So if you have foot drop, you would have loss of dorsiflexion. All right, which is under the the responsibility of the common fibular nerve. The superficial fibular nerve is purely responsible for the inverted foot. Okay, so the common fibular eventually is going to branch off into the superficial and the deep fibular. The superficial fibular is responsible for the inversion of the eversion of the foot, whereas the deep fibular is responsible for dorsiflexion. So if you have loss of superficial, then you would have an inverted foot. You're unable to evert it. And if you have loss of deep fibular, then you're going to have a foot drop because you're unable to dorsiflex. All right, superior gluteal nerve is responsible for the gluteus medius and minimus. So you're going to have the Trendelenburg sign, which means when you're walking, the hip is going to sway to the opposite direction. That's the Trendelenburg sign. And the inferior gluteus, which is innervating the gluteus maximus, is the clinical sign where that's going to be problems with climbing stairs or standing from a seated position. This is the buzzword. All right, that's under the control of the inferior gluteal nerve. Okay, so these are all of the lesions that you should know from this lecture. Again, go into it into greater detail, but there's not much to try to explain or to try to understand from this lecture. All right, now moving on to the cerebrum. Okay, so the cerebrum, the first thing that I want you to know about the cerebrum, obviously, is that it controls all of the functions of the nervous system, either going to come from the cerebrum or from the cerebral cortex, or they're eventually going to go to the cerebral cortex, which means it's a space for processing information from the rest of the body and also motor planning and sending information to the rest of the body. Because of that, we're going to need specific parts of the cerebrum that are responsible for specific things. Now, years ago, scientists gathered together and they decided that we're going to split the cerebrum into specific parts called the Brodmann areas. And we're going to number these Brodmann areas. And based on their number, that's going to tell us what exact role they have. Okay, so you should definitely try to remember the main ones, like the very, very important ones. But by no means should you, spend hours and hours trying to memorize every single Brodmann area, like by number and what it does. You should know generally which part of the cerebrum, like if I point to a specific part, you should be able to tell me this was responsible for this, but you don't necessarily need to know every single Brodmann area's number. Okay, but the main ones is you should know four. So four is primary motor cortex. So first of all, you have the central sulcus separating the frontal lobe from the parietal lobe. All right, and the central sulcus, anterior to it, you have the primary motor cortex. So this is Brodmann area 4. So primary motor cortex, any lesion at the primary motor cortex would cause an upper motor neuron lesion. This is where your corticospinal tracts, the majority of the fibers from your corticospinal tracts are going to be originating from the primary motor cortex, which means if you have a lesion there, that's going to be an upper motor neuron lesion. All right. 6 is the premotor cortex or the supplementary motor cortex. Okay. This is where you decide which movement you want to do. So if you have a lesion at the premotor cortex, it's going to lead to something called apraxia. All right. And apraxia is basically you're unable to do specific movements that involve coordination of multiple muscles, things like biking or whistling, for example. You would need a lot of motor planning to do those complex movements, and that's under the responsibility partly of the premotor cortex or the supplementary motor area. So loss of this section would lead to apraxia. All right. Again, this is just a summary. We're going to go into them, inshallah, soon. All right. The frontal eye fields, which is Brodmann area 8. If you have a lesion at this area, the eyes are going to look towards the side of the lesion. Okay. If you have a patient, for example, who had a cortical stroke and now he can only look to the left direction, you know that most likely the left frontal eye field, because it's towards the side of the lesion, was affected. All right. 3, 1, and 2 are the the primary somatosensory cortex. This is again in the parietal lobe. So again, we said anything anterior or ventral to the central sulcus would be frontal lobe. Anything posterior would be parietal lobe. So 312, this is your primary sensory cortex. Again, any lesion there would lead to hyposthesia or hemianesthesia, which is just loss of the contralateral, like pain and temperature, any sensations from the contralateral body. Okay. Um, 5 and 7, Brodmann areas 5 and 7 is for somatosensory association cortex. So this is basically responsible for knowing, like being able to not just feel things, but knowing what you're feeling exactly. So a lesion in this area would lead to something called astereognosis. And astereognosis is basically if somebody were to put like a water bottle in your hand, you'll know that this is a water bottle, or you'll be able to feel it out and know that this is a water bottle. Astereognosis, which would mean that you're able to feel it, but you're not able to know what you're feeling exactly. So that's responsible. So that's what the somatosensory association cortex is responsible for. Primary visual cortex is here in the occipital lobe. So this is Brodmann area 17. And again, a lesion there would lead to probably blindness or unable to, or at least loss, or at least weakness in sight. 18 and 19 is visual association cortex. So this is similar to the somatosensory association cortex, is knowing exactly what you're looking at specifically. All right. 41 and 42 is primary auditory cortex. So you would have either deafness or you would have loss of hearing or weak hearing. And then we get to the fun ones, which is Wernicke's area and Broca's area. Both of these are for language specifically, but Wernicke's area is for language comprehension. So, for example, if you're speaking and you're making sense, and the sentences that you're saying they make sense, this is under the responsibility of the Wernicke area. Broca's is for speech production. So this is motor speech specifically. This is Brodmann area 44 and 45. Okay, so again, this is Broca's area here, and this is Wernicke area here. All right, it would be Brodmann area 22. Okay. So again, these are the Brodmann areas. We're going to go into them, inshallah. All right. So injury to Broca's area here would cause motor aphasia, which means, first of all, the patient is aware that they're not able to speak. So they become very frustrated. They have broken speech and they have long pauses. But an injury to Wernicke's area, which is receptive aphasia, would mean that the patient is not aware. So he's able to speak, like the words are coming out, but they're nonsensical words and sentences. So you'll see people or books refer to this as a word salad. People are just putting words together that don't make any sense together. Again, the key differentiator here is that the patient is non-aware in Wernicke's area that there's anything wrong. Whereas in Broca's, an injury to Broca's area, they're not able to get the words out at all. So they are aware. Okay, and then you have this thing here called the arcuate fasciculus, which is connecting Broca's area with Wernicke's area. Now, what exactly it's responsible for is not completely clear, but we know that injury to the arcuate fasciculus leads to something called conduction aphasia. Okay, this is where the patient is aware, and the main thing is that they're unable to repeat specific words and sentences, and they have poor object naming. Okay, so you have motor aphasia, Broca's area, receptive aphasia, Wernicke's area, and conduction aphasia, injury to the arcuate fasciculus, which is connecting Broca's to Wernicke's area. Okay. All right. A patient with a parietal lobe lesion presenting with agraphia, acalculia, finger agnosia, and left to right disorientation. Which of the following is affected? This is a bit of a tricky one. So the answer is B. All right. What would A be? So this would be, A would be, if this was the central sulcus here, this would be the primary somatosensory cortex. C would be Wernicke's area, and D would be orbitofrontal cortex. All right, or yeah, the orbitofrontal cortex. So what exactly is B? So this is something that we call the angular gyrus. Now, depending at which area or at which side of the brain is affected, will lead to two different syndromes. All right. First of all, you should know that every person has a dominant lobe and a non-dominant lobe. All right. And usually it has to do with what your dominant hand is. So if you're right-handed, for example, your dominant lobe would be the left lobe. So for most people, the dominant lobe is the left lobe. Okay. So any damage to the dominant or the left parietal cortex, specifically this section called the angular gyrus, would lead to something called Gerstmann syndrome. All right. You need to remember four things for Gerstmann syndrome: agraphia, acalculia, finger agnosia, and left-right dissociation. So agnosia is they're unable to identify the finger. So finger agnosia, they're not able to know which finger, like for example, they can't point to a finger and tell you this is my middle finger, this is my this is my index finger, whatever. Acalculia, they're not able to do any calculations. Agraphia, they're unable to read, and left to right, so disorientation, obviously they can't tell the difference between their left side and their right side. Now this is a dominant lesion. What happens if we have damage to the non-dominant parietal cortex? Okay, so a patient who drew this picture right here, would likely have a lesion in which of the following locations? And these are the same options that we had in the previous question. The answer again would be B, but the main difference again is that this would be a lesion in the non-dominant cortex. Again, so damage to the non-dominant cortex, specifically the supramarginal gyrus, which is again very close to the angular gyrus, which is Broadbent area 40, leads to hemispatial neglect syndrome, which is characterized by agnosia of the contralateral side of the world. All right. So in this case, for example, they're unable to draw the left side of a clock, or they're unable to draw the left side of the face, or like, for example, they don't know or they can't shave the left side of their face. All right. If the damage was done to the non-dominant lobe. Okay, so this is the difference between Gerstmann syndrome and hemispatial neglect or hemi-neglect syndrome. Okay, all right. Now going on to the visual pathway. You guys are going to go into more detail, inshallah, with your head and neck block, so we're not going to go into it too much. But you should know that the left side of your vision is always under the control of the right side of your brain. So you'll see here the green is the left side of your vision, and all of it eventually goes back to the right side or the right occipital lobe, whereas the right side always goes back to the left side. All right. Now it crosses over here in the optic chiasm, which is why if you have a lesion at the optic chiasm, you'll have something called bitemporal hemianopsia, which means two opposite, like the right side of your, or the right side of the vision of your right eye is gone and the left side. So it's the two temporal visions from both your eyes are gone. That's because there's overlapping here in the visual pathways. Whereas, for example, and by the way, the left side of your vision always goes back to the right retina, as you can see here. So it does cross over again and goes to your right retina, whereas the right side of the vision comes back to the left retina. So if you have a lesion at A, for example, you can have a scotoma, but if you have a lesion, let's say hypothetically at this entire section, then you would lose all the left side or the contralateral vision. Okay, if you have a damage to the right side of your retina, if that makes sense. All right, and again, if you have damage to the optic nerve, it's just right anopia because it's supplying your entire visual pathway in your right eye. C would be bitemporal hemianopsia. D would be right nasal hemianopsia, and obviously that's because you're targeting specifically the nasal vision of your right eye. As you can see here, it crosses over the temporal, the nasal vision sort of stays off to the side. So if you have, which is very rare to see, by the way, a lesion at this specific site. And then you have E. If you have here a lesion at E, which is the optic radiation, then you're going to have left homonymous hemianopia. But the main thing that I want you to know is if you have a lesion at the occipital lobe. If you have a lesion at the occipital lobe, you're going to have, obviously, because we said before that um, the right side of your vision from both eyes is under the control, for example, of the left occipital lobe. So if you have a lesion at the left occipital lobe, you're going to have right homonymous hemianopia with macular sparing. Now, the macula is the specific part in your retina, or is a specific part of your vision that's under the supply of both sides of the hemisphere. Okay, both hemispheres. So if you have only like a lesion at the occipital lobe of one side, then you're going to see left homonymous, or you're going to see one sided homonymous or contralateral homonymous hemianopia with macular sparing. And that's because it has dual supply. Okay, does that make sense? Okay, all right. And again, this is what we talked about here. We're not going to talk about that. We'll talk about PCA infarction soon, inshallah. And again, optic nerve, then you're going to have left anopia. Optic chiasm, if it's involved, you're going to have bitemporal hemianopia. Optic tract is right homonymous hemianopia. Again, all of these tracts are going to eventually cross over to go to the other side. And that's why a lesion would lead to right homonymous hemianopia. Okay? All right. A patient with the following visual field defect will have which of the following vessels affected? Again, we talked about circle of Willis. So the answer would be H, or the posterior cerebral artery. Okay? Okay. Again, because the posterior cerebral artery eventually is going to supply the entire occipital lobe, and I told you the macula specifically has dual supply, also from the MCA. So if you have a lesion at the occipital lobe, you're going to have contralateral homonymous hemianopia with macular sparing. Okay, perfect. We're going to take a short break, inshallah, then we're going to continue the rest of these slides. All right. So now we're going to talk about cerebrovascular anatomy. Okay, so we're going to talk about the circle of Willis again. As we mentioned before, it's an anastomosis between the anterior circulation, which is coming primarily from the internal carotid artery, and the posterior circulation, which is coming from the basilar, or sorry, the vertebral arteries and also the basilar artery, forming eventually the posterior cerebral artery. Okay, so if we work our way down, if we work our way up, sorry, we have the vertebral arteries here that are going to give off this branch called the pica, obviously, which we know supplies the lateral medulla. And also, it's going to give off this branch that goes midline, goes down midline, called the anterior spinal artery, which supplies the medial medulla and also goes down and supplies parts of the spinal cord. And before these these vertebral arteries are going to join at the top to form the basilar artery, which supplies the pons, and they're going to give off it's going to give off these branches called the perimedian branches or the pontine branches. And then it's going to give off also the superior cerebellar artery and the posterior cerebral artery. Okay. Now, from the posterior cerebral artery, you're going to see that's already called a PCOM, the posterior communicating artery, which is going to connect the posterior circulation with the anterior circulation. Now, the anterior circulation, as we mentioned, is coming from the internal carotid artery. Okay, so just picture this artery, this internal carotid artery, coming up, and then it's gonna basically give rise to the middle cerebral artery. Okay, and a couple other arteries that are very important, which we'll talk about soon, but also this artery, which is very important, called the anterior choroidal artery. Okay, which we'll talk about it in a minute. And the MCA is going to give off these lenticulostriae arteries, which are also extremely important. Okay, and then from the MCA, you're going to get the anterior cerebral artery, which is going to go up and is going to apply the medial surface of the cerebrum. Okay, and the middle cerebral artery is going to go on and it's going to supply basically the majority of the external part of the brain, so the parietal lobes and part of the frontal lobes, but more laterally rather than medially. The medial parts are going to be supplied by the anterior cerebral artery. Okay, and then you have this artery here called ACOM. Okay, now I want you to know where exactly ACOM is in relation to the optic chiasm. This is very important. So the optic chiasm would be immediately posterior to the anterior communicating artery. Okay, this is very important for a clinical correlation that we're going to talk about later on. Okay, so again, we have this artery here called the internal carotid artery. All right, so the internal carotid artery, it's going to go up and it's going to eventually form the middle cerebral artery, which you can see here. This is basically just a cut section of it. Okay, but right before it goes and it forms the middle cerebral artery, it's going to give off a couple of branches, one of them being the ophthalmic artery, which is a very important artery, which we'll talk about in a minute. Okay, so these are important ICA branches and what structures they supply. So the ophthalmic artery, which is the first branch that the ICA gives off before it becomes the middle cerebral artery. It supplies the retina and also all of the extraocular muscles. But the ophthalmic artery specifically is going to give off another artery, which is called the central retinal artery, which is going to supply the retina. Okay, and obviously that's very important because a lesion there would cause blindness, or at least like transient blindness. We'll talk about that in a minute. Okay, and it gives off the anterior choroidal artery, which is going to supply at least partly the posterior limb of the internal capsule. Do you guys remember what I said was so important about the posterior limb of the internal capsule? First of all, the internal capsule, you could think of it as just this very tiny space where every single tract that we talk about is going to eventually pass through the internal capsule to reach the cerebral cortex. Now, what was so important about the posterior limb? That's where all of the corticospinal tracts eventually go. Okay, so you'll imagine if we have a lesion at the anterior choroidal artery, what's that going to cause? Complete hemiparesis of the contralateral body. Okay, sorry, it's also going to give off hypophyseal arteries, which supplies the pituitary gland. The posterior communicating artery, which is going to which is going to supply parts of the oculomotor nerve. It's also going to give off obviously the anterior cerebral artery, which is going to supply the medial frontal slash parietal cortex for leg motor and sensory area. We'll talk about that in a minute. And obviously MCA for the lateral cerebral cortex. Okay. But the main ones that I want you to remember is ophthalmic and anterior choroidal. The rest, inshallah, we'll talk about. Okay. But these are very, very important to know. Okay, and again, this is just a clearer picture. You'll see here, this is a continuation of the ICA. So ICA here, you'll see the ophthalmic. Again, this is a pretty complicated picture, but if you take your time to really look into it, it's going to be very helpful. So this here is the ACA. You'll see this is the MCA. So this is the ICA here. This is the MCA eventually, and from the MCA, you're going to get these lenticulostriae arteries, which we talked about. You can see them back here. Okay, and from the ICA, you're also going to get this anterior choroidal artery. Okay, the ophthalmic artery is right here. It's going to go on and supply the retina and the extraocular muscles. And obviously, then you have here the MCA going and supplying the lateral surface of the cerebral cortex, and the ACA going on and supplying the medial surface of the cortex. Okay. All right. Again, this is a clearer picture. So these are the lenticulostriae arteries. You'll see here, what exactly does it look like they're supplying? They're supplying a lot of these structures in the internal capsule. Again, this is the internal capsule here. This would be the caudate nucleus, which is part of the basal ganglia. We'll talk about it soon. And these are the arteries that are supplying this internal capsule. The anterior choroidal is coming up like this. I guess it's proximal to where this cutoff is here, so it's not very visible. But you'll see that these structures or these arteries, all of them are very, very important. So the lenticulostriae arteries coming from the MCA, extremely important, as well as the anterior choroidal coming off the internal carotid. Okay, and then you have the ACA here. You'll see it's supplying the medial surface of the of the cortex, while the MCA is going on and supplying the lateral surfaces of the cortex. Okay. And you also have this recurrent artery of Hübner, which is also very, very important. This is coming from the ACA, the anterior cerebral artery. It also supplies part of the internal capsule. That's important. We're going to talk about it. So we're going to talk about the internal capsule and all of its vessels, inshallah, very, very soon. Okay, so again, this is the lenticulostriae arteries. It's very important in a specific disease called the Charcot-Bouchard microaneurysms. Okay, so this is very, very common in elderly patients, especially ones who have been dealing with chronic hypertension for a long, long time. As we know, chronic hypertension can affect the blood vessels, and specifically small blood vessels. So a lot of the times you'll see with very elderly patients with chronic hypertension, they'll have these lenticular striae artery lesions and aneurysms. Okay, and these can cause lacunar strokes. So that's what the name is, lacunar strokes. And since they're supplying the internal capsule, they're going to lead to very, devastating results. It could be hemiparesis, it could be, hemianesthesia, very devastating results. And they also because they're microaneurysms, they're also the most common cause of intraparenchymal strokes or hemorrhages in elderly patients. Okay, so that's these small arteries here, very clinically significant. Okay. Now, this is the internal capsule. Okay, this is the posterior limb. Again, like we talked about, this is the corticospinal tract. So all of it, the entire corticospinal tract is in the posterior limb of the internal capsule. This is its blood supply. So again, this is the anterior limb. Again, this is you're gonna have to sort of flip the internal capsule from these two diagrams. But this is the posterior limb. Again, it's supplied by these lenticular striae arteries. Okay, you have this recurrent artery of Hubner coming from the anterior cerebral artery, again supplying the anterior limb. Okay, and you also have where was it? Yeah. So you also have the posterior cerebral artery supplying also parts of the internal capsule. Okay, but you'll see here this is so important when we talk about the anterior choroidal artery. You'll see right here it's also supplying the genu, or the I guess the this would be the genu of the internal capsule, supplying those parts as well as specific parts of the posterior limb coming from the lenticular striae arteries. Okay, so again, anterior limb from the ACA, okay, from Hubner, recurrent artery of Hubner. The genu from the MCA, specifically the lenticular striae arteries, okay, and the posterior limb from the anterior choroidal and the MCA, the lenticular striae arteries. Okay, all right, perfect. So a lesion anywhere in these arteries, specifically the anterior choroidal or the lenticular striae, would cause hemiparesis because of involvement of the corticospinal tracts. All right, this is very important to know. Okay. All right, so I asked you to know where exactly ACOM is with respect to the optic chiasm. So since it's right, immediately posterior to it, you'll see here this is the anterior communicating artery. So this is the anterior cerebral, and then this is the anterior communicating here. And the optic chiasm is like right immediately posterior to it. So an aneurysm here, or like an occlusion, not an occlusion, but an aneurysm specifically at the anterior communicating artery would cause compression of the optic chiasm, which similarly to a pituitary gland adenoma would cause also, sorry guys, give me another minute. Okay. Sorry about that. So again, ACOM, an aneurysm there would act similarly to an adenoma, and a pituitary adenoma would cause bitemporal hemianopsia. PCOM, if we take a look at where PCOM is, the posterior communicating, it's right at the junction of where the oculomotor nerve would come out of the midbrain. So an aneurysm there would cause compression of the oculomotor nerve, which can cause oculomotor palsy. Okay, and again, an occlusion at the ophthalmic artery, which is a branch of the internal carotid. Is it in this? Okay, it may not be in this diagram. But it would cause occlusion of the central retinal artery, which could cause loss of sight. Now, the specific condition where you have transient occlusion of the central retinal artery, so you'll see a patient who had loss of vision, for example, for 10 minutes or 5 minutes, and then their sight came back. That's called amaurosis fugax. Okay, and this is a transient loss of sight because of transient obstruction of the central retinal artery. Okay. And again, this is the ophthalmic artery. It's going to give off the central retinal artery. You'll see here, this is, I guess you can't see the ICA that clearly, but this is the branch that would give off. Okay, perfect. So a patient with sudden onset contralateral leg weakness and sensory loss greater than arm or face involvement. So again, contralateral leg and leg weakness and sensory loss in the legs. Often with urinary incontinence and behavioral changes, which of the following is affected? Okay, so this is an angiogram. We have leg involvement more than arm or face. Which one is affected? That would be C. So the anterior cerebral artery, we said it supplies the medial part of the cerebral cortex, And if you take a look at like the motor sensory homunculus, which you guys, I'm sure you guys know all that picture, that great picture of the character. But the medial part of the cerebral cortex is responsible for sensation and motor function of the lower part of the body or the lower half of the body, whereas the lateral parts, the lateral cerebral cortex is responsible for the upper limb and the face. Okay, and again, we know that this is an ICA angiogram. So here you have this dye um, in the ICA, and it's going, and it's so this is the MCA here, this is the ACA. Okay, all right. Again, now let's say we take a cross section of the brain, and we want to know what exactly which parts are supplied by which major vessels. This is what it's going to look like. So you'll see a lot of the medial part is supplied by the ACA. The occipital lobe is supplied by the PCA. Obviously, we already know this, and the majority of the rest of the cortex is supplied by the MCA. Okay, and if we take a look at the internal capsule, we'll see that most of it, again, is supplied by the MCA. So this is the posterior limb. This is the anterior limb. Again, we said that the recurrent artery of Hubner is supplying the anterior limb, whereas the lenticular striate and the anterior choroidal is coming from the MCA and the ICA, respectively. Okay, so you'll see here, this is the distribution. And again, this is the ACA here. This is the recurrent artery of Hubner coming from the ACA, supplying parts of the internal capsule. And then the ACA is coming and supplying most of the medial parts of the, like right here, of the cortex. And then this is the posterior cerebral supplying the occipital lobe and parts also of like the thalamus. Okay. And again, this is the homunculus that we talked about before. So you'll see the medial part is, very responsible for like genitals, for example, knees, toes, so the lower limbs, whereas the lateral parts are responsible for the face and the upper limbs and the neck and the head. Okay. And this goes for both sensation and motor function. Okay. This is why in an ACA stroke, you would have loss of motor and sensory function in the lower limbs. Okay, so again, ACA, so it's hemiparesis or hemiplegia contralaterally involving primarily the lower limbs and pelvic floor musculature. Okay, you're like very extremely rarely gonna see a question that's like which the answer for it is ACA stroke that doesn't talk about lower limb hemiparesis or hemiplegia. Okay, so that's like the number one indicator that you're gonna get that this is an ACA stroke is the involvement of the lower limb more than the upper limbs. Okay, you're also gonna have sensory deficits, obviously. Apraxia because it branches to the supplementary motor area, which we talked about before. Anosmia because it does supply parts of the olfactory bulb. Urinary incontinence because of the medial paracentral gyrus. And again, which vessels specifically? It could be the perfor. Again, this is not really related, but the perforators, which could be involved additionally to an ACA stroke, it would cause all these things. So if it's medial lenticular striate or the recurrent artery of Hubner, you could also have involvement of the internal capsule. Okay. So occlusion of the middle cerebral artery. This is the one that a lot of the time you're going to get your questions on MCA just because it's more common to see. And this is going to be paralysis or weakness of the contralateral face and arm, again because of the motor and the sensory homunculus. Apraxia, again because of the supplementary. Just think about the cerebrum that we studied before. All of the Brodmann areas there that could be affected by an MCA stroke, those are the signs that you're going to see. Okay, so for example, if it's damage to the dominant hemisphere, then you're going to see Gerstmann syndrome, or it's going to be aphasia if there's Broca's, if there's Wernicke's, and if it's non-dominant, then you could see hemi-neglect syndrome. All right, and depending on how proximal or how distal, I guess, the stroke would be, you could see involvement of the basal ganglia, for example. And you could see lacunar infarcts, which we talked about before, if there's involvement of the lenticular striate arteries of the MCA, that would lead to contralateral hemiplegia and hemianesthesia. Okay? So, again, ACA, you're going to see lower limb involvement. MCA, you're going to see upper limb and face. And you could see signs such as like aphasia, Broca's aphasia, Wernicke aphasia, or even Gertzmann or hemi-neglect syndrome. Okay. Now for PCA, mainly we're going to look at the visual side effects. So since it applies the occipital lobe, we're going to see visual agnosia. We're going to see contralateral homonymous hemianopsia with macular sparing. We talked about why it has dual supply from the PCA and the MCA. Cortical blindness with bilateral involvement of the optic lobe branches, memory defects, and you can have prosopagnosia, which is a disorder of face perception, and this is because of the visual damage to the visual association cortex. Okay. And depending on, again, how deep the stroke is, you could see signs of injury to the thalamus, which we'll talk about soon. Could lead to things like central pain syndrome. Talk about it in a minute. Okay, so again, the strokes of the major vessels are fairly easy. Inshallah, you shouldn't have too much trouble with those. The real kicker is to know like the supply of the internal capsule. Okay, so just make sure you study the lenticular striae arteries, the recurrent artery of Hubner, the anterior choroidal, things like that, and you should be good, inshallah. And to know what level, um, what level the stroke happened at, because a cortical stroke in like one of the major vessels could cause contralateral hemiparesis, for example, but so could an internal capsule stroke specifically, or a brainstem stroke specifically. So you got to look at all the other signs to know what level we're talking about. Okay. Okay. Now, patient sustains trauma to the site indicated by the arrow, which is right here. Which of the following most closely resembles the patient's head CT findings? Okay, so is it A? You'll see this little thing here. Is it B? You'll see this giant hemorrhage right here. Is it C? And take a look at the like the ventricles, I guess, or the star sign in the middle. Or is it D? So the answer is D. Okay, so take a minute and try to think about what the other findings would be. So this, first of all, we know that this is an epidural hematoma, okay, because of the pie shaped. But this is a subdural hematoma, okay, because of the bridging veins. This is an intraparenchymal hemorrhage, and this is a subarachnoid hemorrhage, okay. Again, here the site that we talked about here is called the pterion. This is where specifically the middle meningeal artery is very close to the surface of the skull. So if you have trauma to this site, then you can get involvement of the middle meningeal artery, which can cause a epidural hematoma. Okay, I'll show you in a minute a picture of the middle meningeal artery. Okay, so again, if it's convex or it's lens shaped, then this is middle meningeal artery and this is an epidural hematoma. If it's a banana shaped, then it's a subdural hematoma, and this is because of the bridging vein. So this is a venous hemorrhage. This is an arterial hemorrhage. Okay, so epidural hematoma, we already talked about it. It's an arterial because of the MMA, and you'll see lucid interval in these patients, which means somebody gets a trauma to the head, they're maybe knocked out for a couple of minutes, and then they're up, and then they're fine, and then they get a lucid interval where they're like almost comatose, and they're very very tired, and they're losing consciousness, and they're in and out of consciousness. That's called the lucid interval. You're going to see that with epidural hematomas. Okay. Subdural hematomas you're going to see with elderly patients. Okay, so these elderly patients, a lot of them are going to have chronic subdural hematoma. So it's not going to be very symptomatic at first, but eventually it can cause symptoms of dementia. So it can cause some similar findings. And this is what it would look like. It would look like almost like a banana crescent shaped. And a subarachnoid hemorrhage is very, very easy to know. Usually you would see that with Berry aneurysms or aneurysms in the circle of Willis, specifically either like ACOM or PCOM. It would be a subarachnoid hemorrhage, obviously, and it would be described as like the worst headache of a person's life or a thunderclap headache, okay? But it's going to be, extremely symptomatic right away. Sorry. So again, this is a picture for you guys to take a look at the middle meningeal artery. So this is the middle meningeal artery here. As you can see, it's a branch of the external carotid, so not the internal carotid. A branch of the external carotid. It's coming out right here, and then it's going to branch off. It's going to supply the dura. And then if you take a look here, this is the superior sagittal sinus. So this is a venous structure, and from this venous structure, which are little veins draining into the sinus, you have your bridging veins. Which, if you peel back this layer of the dura, you'll see these bridging veins, and if you have shearing of those bridging veins for whatever reason, it's going to be a subdural hematoma rather than an epidural that you see with MMA. Okay? Okay. Now, moving on to the thalamus, I want to first draw your attention back to the development lecture where we talked about how the diencephalon gives rise to thalamus, the hypothalamus, and the epithalamus. Okay, so I want you to take a look here. This structure right here is the thalamus, all of this. Okay, the subthalamus is right above the midbrain. There's a subthalamic nucleus right here. And the hypothalamus is right here. It's going to give off this median eminence to the neurohypophysis or the posterior pituitary. Okay, so these are all structures coming from the diencephalon. Okay, all right, so let's get to it. So when we're talking about the thalamus, first of all, we want to know what the thalamus is. So the thalamus is just it's gray matter. So these are cell bodies, these are nuclei, and that's where the second order neurons for the anterolateral system or the spinothalamic tract and the dorsal column or medial meniscus are. So remember we talked about ventral posterior medial and ventral posterior lateral, VPL and VPM, nuclei of the thalamus. Eventually, they're going to project to the primary somatosensory cortex. Okay. But other than that, it also has a lot of important cell bodies that's responsible for things like consciousness, things like mood and behavior, things like memory. So it's the thalamus is very, very important. So if we just take a minute to orient ourselves, this is again a horizontal section through the cerebrum. Okay, this is the thalamus. Um, all of these together are going to form your basal ganglia. Okay, there's a bunch of other structures there too, but this is the thalamus. And in between parts of the basal ganglia and the thalamus is the internal capsule, where a lot of these vessels are eventually going to make their way up to the cerebral cortex. Okay, and this is the lateral ventricles. These are the lateral ventricles, if you could see here. Okay, and if we take a look here, like a look at the midbrain, or sorry, the brainstem. This is the brainstem from posterior view, right above the midbrain. Okay, you're gonna see like the crus cerebri of the midbrain, and then right above that, you're gonna see the thalamus. Okay, so it connects directly to the brainstem. All right, and you have these inferior and superior colliculi. Okay, very, very important to know the relationship between all of those things. So again, what exactly does the thalamus do? It basically just connects the cortex, the cerebral cortex, to the brainstem and thus the spinal cord. Okay. Now, again, let's take another minute to sort of get the anatomy perfect. So this is a coronal section. You'll see here, this is the whole this whole thing is the thalamus. You'll see here there's this thing in between. Now this is called here the this is a lamina called the um intramedullary lamina. Okay, and it's going to sort of form a Y shaped in the middle of the thalamus, and um from this separation, from this Y shape, you'll know where certain nuclei are. Okay, so this would be the anterior nucleus, for example, of the thalamus. Okay, and again, this is the internal capsule. These are parts of the basal ganglia, the globus pallidus externus, the claustrum, the putamen. This is the corpus callosum connecting the two hemispheres together. And these are the mammillary bodies, which is part of your limbic system. Okay, and again, this is the substantia nigra. So this right here would be like part of the midbrain. So you see the thalamus is right above that. Okay. All right. Great. Now let's move on to the specific nuclei. So again, I mentioned you have your internal medullary lamina right here, which is which is going to separate different nuclei of the thalamus. So if we take a look, this is the Y shape that I was talking before. This is your anterior nuclei. This is your lateral dorsal, lateral posterior, and again your medial, your ventral anterior, ventral lateral, and then your ventral posterior, which is VPL and VPM, and then the pulvinar nucleus here, and then connected to it is the lateral geniculate body and the medial geniculate body. Okay, we're going to take a minute to discuss all of these nuclei. Again, the point of learning about the thalamus and learning about all of the thalamic nuclei is not to, really hone down on all of the nuclei one by one and figure out exactly what they do. It's extremely complex and it's likely too much detail for you to go into. It's just very important to know the general. First of all, you know the general function of what each nuclei does, very generally speaking, and also know the connections. Okay, so know, for example, this is associated with memory, so it's going to be, connected to the hippocampus or the amygdala, for example. All right, whereas this is responsible for more for behavior and function, so it's going to be connected to the prefrontal cortex. All right, so just things like that in order to make it easier for you. Okay, so starting with the anterior nuclei. Okay, this is connected with the mammillary bodies and the hippocampus, and it's linked with memory. That's all I want you to know. All right, linked with memory, it's associated with the mammillary bodies and the hippocampus, and these are part of your limbic system too. Okay, dorsomedial nucleus, it's connected to the prefrontal cortex and it's linked with emotional behavior. All right. The ventral nuclei are a little bit more important because they're part of motor planning. So they connect with different parts of the brain. So with ventral anterior it connects to the basal ganglia. So that's and the premotor cortex. So it's responsible for motor planning, where the ventral lateral connects with the cerebellum. And it's the same thing. It's motor cortex and motor coordination is responsible for all those things. All right. VPL. Again, we mentioned it. Body sensation from the spinothalamic and the dorsal column or medial lemniscus going up to the somatosensory cortex. VPM, same thing, but it's just sensation from the contralateral face, also going up to the somatosensory cortex. Pulvinar is responsible for visual processing and attention. And then the lateral dorsal finally is part of the limbic system, so it connects with the cingulate gyrus, and it's responsible for emotional and memory integration. Okay, so the main ones that I want you to really, really pay attention to is VPL and VPM, and maybe for later on, ventral anterior and ventral lateral. Okay, for the sorry, for the motor planning. Okay, so again, this is the blood supply of the thalamus here, and again, what I want you to know mostly is that the same arteries that we talked about before that are supplying parts of the internal capsule also go ahead and supply parts of the thalamus too. A lot of the supply comes from the PCA, as we looked at before. So this is the posterior cerebral artery here, and then this is the PCOM. It's connecting obviously the posterior circulation to the anterior circulation. You'll see these posterior choroidal arteries supplying the posterior territory of the thalamus. The paramedian is coming from the paramedian artery, all right, and the thalamico-geniculate artery. Now, this is a normal, like this is the most common anatomical variation, all right. Another anatomical variation, which is very clinically important, is something that looks like this, all right. This is where, again, just to orient ourselves, this is the basilar artery, and this is the PCA, okay. In this diagram, what we see is that this specific artery is supplying both thalamic or both thalami, I guess, both of the thalamuses and all of the thalamic nuclei are coming from this one artery. Okay, this artery is called the artery of Percheron. Okay, and it's an anatomical variation, so it's not seen in all patients, but it's very important because if we have an occlusion of this artery in patients who have this anatomical variation, it's going to lead to a bilateral thalamic infarction, which is devastating, has devastating effects on a patient's neural functioning. Okay, so a basilar artery embolus or an occlusion at the artery of Percheron. Again, if there was a since most of the supply is coming from the posterior cerebral artery, if there was an occlusion here, like at the top of the basilar artery, then it would be the same effect as an occlusion at the artery of Percheron. You would cut off supply to the thalamus bilaterally. Again, occlusion would cause bilateral medial thalamic infarction. Okay, and since all of these structures that we talked about are going to be controlled by the thalamus, it's going to lead to patient being in a comatose state, maybe agitation, hemiplegia or hemisensory loss, ophthalmoplegia, obviously because of the pulvinar nucleus that we talked about before, has a very poor prognosis. So even when these patients are able to recover, they're most of the time they're unable to gain back all of their neural functioning. Okay, and this is what it would look like. So this is a bilateral medial thalamic infarction. Okay. All right. Patient with a prior thalamic stroke now presenting months later with severe burning pain on the contralateral side of the body, triggered by light touch, allodynia, despite decreased sensation. Which of the nuclei are affected? Okay, so this is another name for this is central pain syndrome. Which nuclei is this? That would be the VPL or the VPM nuclei, which is right here. Okay, and again, why is that? That's because we have the spinothalamic and the dorsal column or medial lemniscus, but specifically the spinothalamic tracts going up and synapsing, or the second order neurons synapsing in the VPL and the VPM. Okay, if we have a lesion at the space, we can have, complete hemisensory loss on the contralateral side of the body. But if the specific fibers are also affected in this lesion, so it's not just the nucleus, it's also the fibers, then later this could lead to something called the central pain syndrome, where it's just the patient's going to have chronic pain on one side of the body because of involvement of these. They're going to be extremely sensitized, these neurons, to pain, where anything could set them off and anything can cause very, very major pain. Okay. So, thalamic pain syndrome or central pain syndrome commonly results from a lacunar stroke involving thalamoperforating branches of PCA, which supply the ventral posterior nucleus of the thalamus, so both the VPL and VPM, and this is just a diagram so you guys can remember the tract that we talked about, can cause a pure hemisensory loss. Central pain occurs if the lesion affects the anterolateral system, which is the spinothalamic tract, and VPL. In these patients, the initial analgesia is replaced by spontaneous aching, burning pain, which is often excruciating and may be provoked by light cutaneous stimulation. Okay? All right, so this is a lesion affecting specifically the ventral posterior lateral nucleus, or it could be VPM. Okay? All right, a lesion at the lateral geniculate body would generate which of the following visual field defects? And just so that we can orient ourselves, this is where the lateral geniculate body would be. Okay, so the answer, these two are repeated, so ignore D. But the answer would be C. Okay, so you would have complete contralateral homonymous hemianopsia. And why wouldn't you have macular sparing? Again, remember that we said the macula is supplied by both the PCA and the MCA. So if you were to have a lesion at here, for example, here at 3, at C, if there's a PCA infarct, then you would have B, which is contralateral homonymous hemianopsia with macular sparing. But since the lesion is more proximal, in this case, it's the lateral genicular bodies, which involves all of the optic radiations from one side of your visual field, then it's going to cause complete contralateral hemianopia. Okay, so the lateral genicular body, we just talked about it, is a visual relay nucleus. So a lesion in so again, this is the metathalamus that we're talking about here. So this is not, technically it's not part of the thalamus, it's the metathalamus. It's connected to the thalamus though. Results in contralateral homonymous hemianopia without macular sparing, again, because it's not a PCA lesion or it's not a PCA stroke. Whereas the medial genicular body, again, this is the lateral genicular body here, and this is the medial genicular body. Remember we talked about, I'm not sure if you remember this from your brainstem lectures, but the superior colliculi is also part of that visual relay station, and the inferior colliculi is part of that auditory relay station. So medial genicular body is an auditory relay nucleus, and an MGB lesion results in bilateral partial hearing loss. Okay? And it's important to know that this is the type of lesion that you would see. Okay, you're gonna go into this in much more detail in the following block, I think head and neck. But it's good to know from now that this is the lesion that it would cause. Okay. Moving on, who can tell me what the diagnosis is here? So we have this MRI finding, this patient, okay, and melatonin. So this is Perry-Nose syndrome, and because we have melatonin, we know that this is because of a pineal gland tumor, okay? So what exactly is the pineal gland? The pineal gland, as you can see, it's right here, okay? And it's in part of the midbrain, and if you have a pineal gland tumor, then that's actually going to obstruct. First of all, what it is, it's the pineal body. It's basically it's responsible for secreting melatonin to regulate your circadian rhythm. The tumor can compress a lot of the midbrain structures and a lot of the midbrain's functions that have a lot to do with ocular function. So it's going to compress superior colliculi and the pretectal area, producing Perry-Nose syndrome. It can also cause cerebral aqueduct compression, so it also can cause hydrocephalus. Okay, but that's why these patients have this visual finding. It's going to be almost like a visual process. They're not able to look up, look horizontally. They're not able to move their eyes horizontally. Okay. Now we're going to talk about the subthalamus. Now, so the subthalamus has one main important nucleus that we have to talk about, which is the subthalamic nucleus, which we're going to talk about more in detail when we come to the basal ganglia lectures. But for now, all I need you to know is that the subthalamic nucleus, a lesion in that space would result in hemiballismus, which is a contralateral involuntary flinging movements or one or both extremities. So this is what it would look like. Okay, so this is the subthalamus. And the blood supply is PCA against the thalamoperforating nucleus, and this is where it is. Okay, so this is the subthalamic nucleus, and this is where the substantia nigra is. So it's right underneath the thalamus. This is the thalamus, by the way. Okay. All right. Moving on to the cerebellum. So the cerebellum, other people like to call it the little brain. Basically, where we say that the brain itself, that the cerebral cortex itself has gyri and gyri and foci, we say that the cerebellum has folia. Okay, so these folia are basically just to increase the surface area of the cerebellum. Now, just to orient ourselves a little bit more, at the cortex here, or sorry, at the surface here of the cerebellum, you have gray matter, which are all of your cell bodies. There's a layer there that's very, very important for you guys to know in your physiology. It's not for me to cover today, alhamdulillah. And the white matter here is where all of the tracks are going to be coming down. There are also some deep cerebellar nuclei in the center of the cerebellum that are very important to us that we're going to talk about soon. Okay, so um, moving on, this is the general anatomy. So we have the anterior lobe here of the cerebellum and the posterior lobe here. And this thing right here, we call that the flocculonodular lobe. Okay, now if we take a look at sort of um, the homunculus of the cerebellum, just like how we have a homunculus for the cerebral cortex, we have a homunculus for the cerebellum. First of all, the cerebellum is responsible for mainly motor planning and correction. So a lot of people say that it's a comparator. So if you're planning on doing a movement, let's say I'm planning on picking up this water bottle, all right? How do I know that my arm won't overshoot and it'll reach for something that's, beyond this water bottle, or it'll undershoot and reach for something right in front of it? That's because we have our cerebellum that's actively, as we're making a movement, it's correcting our muscles and it's telling our brain and our spinal cord what muscles we should contract and relax so that we can perform a specific movement. So it's a real-time comparator. It's very important for this. Okay. Now, I want you to also know that we can separate the cerebellum into specific parts. So if we take a look at this structure here, the homunculus, we can separate it into the cerebrocerebellum, which we also call the lateral hemispheres. We can separate it into the vermis, which is right here in the middle, and the paravermis, which is right here off to the side, right, lateral on either sides of the vermis. And then the flocculonodular lobe here, which we'll talk about in a minute, is responsible for a couple of very important things. Okay. And in each of these different parts of the cerebellum, you have one or two important deep cerebellar nuclei that um, play a very, very important role in that specific section's functions. Okay, so if we again take a look at this homunculus, we'll see that the vermis supplies the trunk. Okay, so you'll see here, this is a person. This is the person that we're going to be using as our guide today. So the vermis is supplying a lot of the muscles of the trunk. So again, we'll know that a lesion of the vermis would cause truncal ataxia, for example, whereas the paravermis is supplying the extremities. All right, and what does the lateral hemisphere do exactly? We'll talk about it in a minute, and the flocculonodular lobe. Okay. Okay, remember when I said we have those deep cerebellar nuclei? Well, they're called we have the fastigial nucleus. We have the interposed nuclei, which is made up of umbiliform and globose nuclei. And we have the dentate nucleus. And finally, we have the flocculonodular lobe. Okay, so the fastigial nucleus is right here in the vermis. So the fastigial nucleus would be right here in the middle. And this is responsible for axial or trunk control and balance. Okay, so the interposed nuclei, which are the emboliform and the globose nuclei, in the paravermis, they're responsible for limb coordination. Again, we said that the paravermis is going to control your limbs. So your upper limbs and your lower limbs are going to be under the control of the paravermis. The dentate nuclei, which are in your lateral hemispheres, your cerebrocerebellum, okay, is going to be for very fine tuning things like motor planning and fine movements. Okay. And the flocculonodular lobe, finally, it's going to be connected to the vestibular nuclei. So a lot of people also call the flocculonodular lobe, they call it the vestibulocerebellum. And it's because it's connects to the vestibular nuclei and it's for balance and eye movements. Okay. Now, how exactly does the cerebellum have all of these nuclei? Like, how exactly does it connect to different parts of the nervous system, to the brain, whether it's to the brain, whether it's to the thalamus, whether it's to the spinal cord? Well, we have the peduncles, obviously, same as how we have peduncles in the cerebrum. We have cerebellar peduncles, and we saw them in the brainstem lectures. Okay, so there's a very important table that I want you guys to look at. After everything, it's a great summary. I think it's here. Actually, it might be in the following slides, but it's very important when we look at what structures are leaving and entering specific peduncles. Okay, so for one, we know that we have this dentate nucleus here. So the dentate nucleus, we said already that it's going to be in the cerebrocerebellum and the lateral hemispheres, and it's going to be responsible for specific motor planning. Okay, the specific tracts that are going to be connected to the dentate nucleus are called dentatothalamic tracts. So it's going to be connecting the thalamus to the cortex. So dentothalamic fibers. All right, and these fibers are going to be leaving, or they're going to be exiting through the superior cerebellar peduncles. Okay. One thing that's very important, this is the main idea that I want you to know, because again, all of this is pretty complicated anatomy, but if you understand the main topic, then inshallah you'll be good. All of these structures, so all of these tracts that are going to be coming from the dentate nucleus and going to the cerebral cortex through the thalamus, so the dentothalamic fibers, they're going to be decussating. And what did we say before about decussation? If it decussates, then it's on the contralateral sides, right? But here, it's decussating, and then it's going to the contralateral motor cortex. And if these structures, if we said that the dentate nucleus controls fine motor planning, and it goes to the contralateral motor cortex, and the motor cortex supplies the contralateral side of the body, that means that basically the fibers that are going to come down from the motor cortex to the spinal cord to supply the specific muscles are going to be ipsilateral to the cerebellar hemisphere. Do you get what I mean? Since this is crossing over once in the cerebrocerebellar peduncle, and then it's going to cross over again in the pyramidal decussation in the medulla, that means if we have a cerebellar lesion in the left lateral hemisphere, or in the left dentate nucleus, then we're going to be seeing left-sided cerebellar symptoms. Okay? Because again, it's projecting to the contralateral motor cortex, and the motor cortex is going to project to the contralateral body. Okay? So that's the main idea that I want you to get. Okay, so now we talk about the cerebellar syndrome specifically. We said the anterior vermis, and the vermis specifically is responsible for trunk muscles. So if we have an anterior vermis syndrome, you're going to have atrophy of the rostral vermis. It's going to involve the leg region, anterior lobe, and it's going to be mainly gait, trunk, and leg ataxia. Okay? Posterior vermis, which is going to involve the flocculonodular lobe, you're going to see nystagmus and things like that. You could also see truncal ataxia, and it can be because of tumors. One thing that I want you to know about anterior vermis, it's very, very high yield to know that it's associated with alcohol abuse. Okay, so alcohol abuse, like chronic alcohol use, it's going to cause anterior vermis syndrome, atrophy of the rostral, atrophy of the anterior vermis or the rostral vermis, which is going to lead to gait, trunk, and leg ataxia. Okay, posterior vermis, flocculonodular lobe, usually it's because of tumors, medulloblastomas or ependymomas. Truncal ataxia, and also because of involvement of the vestibular nuclei. You can see things like vertigo, nystagmus, things like that. All right, whereas a hemispheric syndrome, which involves the hemisphere or the cerebrocerebellum, again, we said that the nuclei in the cerebrocerebellum is the dentate nucleus. You guys remember that? Usually also because of tumors. Arm, leg, and gait ataxia, just like everything else we discussed, plus ipsilateral cerebellar signs. Okay, do you guys remember why? Because it projects through the superior cerebellar peduncle to the contralateral cortex, which then projects its fibers to the contralateral body. So it's gonna be like double crossing over. It's gonna end up being ipsilateral. Okay. Okay, now a patient with the following examination findings has a lesion in which cerebellar lobe or nucleus. Let's take a look at this. So this is in this case, the examiner would be asking the patient to do this. So this is called dysdiadokinesia, and it's seen in lateral hemispheres because we said that this is that the lateral hemispheres or the dentate nuclei are responsible for fine motor planning. Okay, so a lesion there would lead to cerebellar signs, one of them being dysdiadokinesia. Okay, all right. Now moving on to basal ganglia. Now, personally, basal ganglia was one of my like the lectures that I think that took me the hardest or the longest to really try to understand, just because the circuits are very confusing if you try to do them, you know, just purely with no background. But inshallah, yani, we should get through it without much trouble. So again, just to orient ourselves again, we said that this is the thalamus. Now, the basal ganglia has a couple of different parts. The parts of the basal ganglia specifically are the caudate nucleus. The caudate nucleus is this right here. This would be the caudate nucleus. And the caudate nucleus sort of, it's sort of this long structure. So you'll see a head of the caudate nucleus, and then also see a tail of the caudate nucleus. So this is the head, and imagine it just sort of, swirls around, and then this would be the tail of the caudate nucleus, and the tail is linked to the amygdaloid body. Um, and then the caudate nucleus is also connected to these structures here. And all of these together form the basal ganglia. Now, these structures here, this would be the putamen, and these two together would be the globus pallidus. This is the globus pallidus externa. This is the globus pallidus interna, sorry. Okay, now the caudate nucleus and the putamen together are known as the striatum, whereas the putamen and the globus pallidus are known as the lentiform nucleus. Okay. Now, the main thing that I want you to know about the basal ganglia is that it's responsible also for motor planning and for motor and knowing how to inhibit certain movements when we don't want to make any movements, and how to inhibit unwanted movements when we want to make specific movements. Like, for example, I would like to reach and grab this glass, okay? But I don't want to, at the same time, when I'm going and reaching for this glass, I don't want to be moving any of my other muscles. So the basal ganglia is going to be responsible for initiating the movement of, me reaching for this glass, and at the same time inhibiting any other unwanted movements. Okay, that's why in lesions where the basal ganglia is involved, you'll either see a bunch of unwanted movements, and at the same time trouble making any purposeful movements, any actual purposeful movements. You're going to be unable to do them. That's why you'll see a lot of these patients with like Parkinson's disease, for example, with with a tremor, for example, with a resting tremor, or even an intention tremor when they're going to reach for anything. And that's because of damage the um, to the basal ganglia. Okay, so how exactly? First of all, let's talk again about the anatomy. So the caudate and the putamen together is the striatum, and this is the major input. So if you're making any decision to um, make a movement, then those signals are going to go first to the striatum, so either the caudate or the putamen. The putamen and the globus pallidus together are called the lentiform nucleus. And the globus pallidus is the major output nuclei. So the input's coming into the striatum, output's coming out from the globus pallidus. Okay, the subthalamic nucleus is for the indirect pathway modulator. And then the substantia nigra, which is again a very, very important part of the basal ganglia, is for dopamine input. The compactus for dopamine input, and the substantia nigra pars reticulata is for the output nucleus. Again, this is the anatomy if you want to look at it again. This is the caudate nucleus, the head of it, this is the tail of the caudate nucleus. Internal capsule, this is the thalamus, this is the subthalamic nucleus, this is the putamen, globus pallidus externa, globus pallidus interna. Okay? Okay, let's get to it. So we have the direct pathway first. Okay, so let's say for a second that, ignore this for a second. I want you just for now to ignore anything that has to do with the substantia nigra. Okay, let's say we decide to make a movement. I would like to reach and grab this water bottle. Okay, my cerebral cortex is going to make that decision. It's going to go to the major input, which is the striatum, so it's the caudate or the putamen, and it's going to send glutamate. It's gonna basically send these glutamate neurotransmitters to activate the striatum. Okay, striatum, what it does is that it's going to go and it's going to send GABA, which is an inhibitory neurotransmitter, to the globus pallidus internus. Okay, so and when that happens, the globus pallidus internus, what's going to happen is that it's going to be secreting, or it's going to be having a much weaker stimulus to its next target. Okay, and the next target happens to be the ventral anterior and the ventral lateral complex of the thalamus. Remember what I talked about before about how the ventral anterior and ventral lateral nuclei are responsible for motor planning, specifically with the basal ganglia? This is where it comes into play. Okay, now the globus pallidus internus normally would inhibit these nuclei from the ventral anterior and ventral lateral complex of the thalamus. Normally, they would inhibit it, again using GABA. But if they're being inhibited by the striatum, then you would have disinhibition. Does that make sense? Disinhibition of the VA and VL complex of the thalamus, which frees it to go ahead and activate the frontal cortex again to go and do that movement. Okay, does that make sense? So this is a direct pathway. This is where you're trying to increase movement. So again, recap. Cortex goes and activates the striatum through glutamate neurotransmitters. The striatum goes and it inhibits through GABA the globus pallidus internus. Now, globus pallidus internus normally would inhibit this. Okay, and try to think of the dotted, like the dashes with a space in between them means that this is being like this process is being inhibited. So this process, this inhibition is being inhibited. So you're freeing up the VA and VL nuclei to activate the cortex, so you're able to produce that movement. Okay. Now, the substantia nigra pars compacta, okay, acts on these D1 receptors, which are positive, which are glutamatergic receptors, which means they accept glutamate, so they're excitatory receptors. What it does is that it sends dopaminergic neurons and also activates the striatum at the same time. Okay, so what it does is that it's producing a much more powerful force and a much more like just a very strong modulator of this entire process. So it's a positive modulator. The goal of substantia nigra and the dopaminergic neurons is to also increase movement. Okay, so let's say for example, we have loss of these dopaminergic neurons. This entire pathway would be inhibited in a way, or it would be weakened a lot more because you don't have this modulatory effect or this additive effect coming from the substantia nigra. Okay, and that's what happens in Parkinson's disease. Okay, so again, what did we say? The substantia nigra pars compacta increases the excitatory stimulus, which increases movement. Now, Parkinson's disease, which is defined as the loss of dopaminergic neurons, causes trouble initiating movements because you're not able to activate the direct pathway and lead to the disinhibition of the VA-VL complex. Again, we want the direct pathway to be inhibited at rest, because at rest we don't want to be making random movements. But when we decide to initiate a movement, then we want these dopaminergic neurons to go and excite the striatum, and that doesn't happen in Parkinson's disease, which is why one of the main characteristic findings of Parkinson's disease is trouble initiating movement. Okay, so this is the direct pathway. The indirect pathway is a lot more complicated. Okay, and I don't want you to go into, at least not for the purposes of this crash course today, because you should know it by now, inshallah, if you've read all of this. But this also involves the globus pallidus externa and the subthalamic nucleus. Okay, but again, the effect of the indirect pathway in this case would be to decrease movement. So in this case, the indirect pathway, we would want to inhibit any movements at rest. Okay, so what D2 does, what the substantia nigra does, in the same way where it activates the direct pathway to increase movement, the substantia nigra would also inhibit the indirect pathway, which again is responsible for inhibiting movement, So we're inhibiting the inhibition of movement, which means the net result of dopamine is to increase movement. Okay, so again, the loss of dopamine in the indirect pathway would increase the indirect pathway activity. And the whole point of the indirect pathway is to decrease movement. Okay, which would mean in one way or another, if you follow this table, you would increase the inhibition of the thalamus from the globus pallidus interna, and you would decrease cortical activation, and this leads to bradykinesia, which is another very important characteristic finding of Parkinson's disease. Okay, so again, just this is all important in the context of Parkinson's disease. The role of dopamine is always to increase movement. Okay, you can either do that with dopamine by activating the direct pathway to initiate movement, or to inhibit the indirect pathway to do movement or to increase movement. If you have loss of dopaminergic neurons, then you're going to have trouble initiating movement because of inhibition of the direct pathway, and you're going to have bradykinesia because of activation or overt activation of the indirect pathway, indirect basal ganglia pathway. Okay. And again, if you understand that point enough, if you understand that dopamine is an excitatory thing, at least for movement, it's pro-movement, then you'll know why Parkinson's disease has all of the findings that it does. Okay? The subthalamic nucleus is also very important for a specific thing, which we'll talk about soon, which we already did actually, but we'll talk about it more. Okay, now, a 45-year-old patient with progressive involuntary jerky movements, chorea, behavioral changes, and cognitive decline with a family history of similar illness. So in this case, at this point, you should already have a diagnosis in your head. Which of the following labeled structures is most likely affected? And take a minute to try to answer this. So the answer is B. Okay. And what did we say? So first of all, this is Huntington disease or Huntington syndrome. And Huntington disease is basically loss of these neurons in the striatum, specifically in the caudate nucleus. Okay, but you can attribute it to the striatum in general. Okay, what would the other ones be? So A, for example, is just the cerebral cortex. B is the answer, that's the striatum. C is the globus pallidus externa. D is the globus pallidus interna. E is the thalamus. F, I think, would be the subthalamus, and G and H would both be the substantia nigra, which are different parts of the substantia nigra. Okay, so Huntington's disease, loss of GABAergic neurons in the striatum. So GABAergic means they're what? They're inhibitory. And what did we say before about the globus pallidus, specifically the globus pallidus internus? It's going to inhibit the VA and VL complex of the thalamus. So if we have inhibition or if we have degeneration of these neurons, this is going to be hyperactive, and we're going to get chorea, or we're going to get a lot of these unwanted movements because of overt activation of the VA and VL complex of the thalamus. Okay, so this is an autosomal dominant trinucleotide repeat expansion in the HTT gene. And this is a familial disease, so you'll see a family history of this, and you also see dementia and marked personality changes. You could see things like loss of inhibition, depression, dementia, all these things. Okay, and it's because of primarily loss of GABAergic neurons in the striatum, specifically the caudate nucleus. So if you lose this right here, the caudate and the putamen, you're losing basically the inhibition of the globus pallidus, which is going to eventually lead to the overt activation of the thalamus. Okay, perfect. Now for the subthalamic nucleus. So if we go back here, the subthalamic nucleus, what it's going to do is it's going to activate the globus pallidus internus, which is going to inactivate or to inhibit the thalamus. So if we have loss of the subthalamic nucleus, it's going to be the same thing. This is going to be not as active, so less active, and then we're going to have disinhibition of the thalamus, and it's going to lead to the hemibilismus thing that I talked about before. Okay, so the subthalamic nucleus normally exerts an excitatory action on the globus pallidus internus, which again, you can think of globus pallidus internus as like the enemy of the thalamus. It always wants to inhibit the thalamus, and the subthalamic nucleus is on the same page. It's on the same side. So if that's not there, the globus pallidus internus is not going to have as easy of a time inhibiting the thalamus, and you're going to have a lot of these unwanted movements. So you're going to have hyperkinetic signs, which is in this case hemiballismus. Okay, just make sure for basal ganglia you know the general function of things. You know generally that dopamine is pro-movement. The subthalamic nucleus is, and the globus pallidus internus is against movement. So if you have disinhibition of those, you get hyperkinetic signs, and same with the striatum. Okay. Okay, moving on to the limbic system. Now, the limbic system is responsible for things like memory, it's responsible for things like homeostasis, it's responsible for things like smell. We're not going to focus on smell too much just because you guys are going to talk about that more in your next block. But for now, the main ones that I want you to know, the major limbic structures are the hippocampal formation, which is obviously the hippocampus, the fornix, so this is the fornix here, the hypothalamus, the amygdala, which is at the end of the hippocampus, the thalamus, specifically the dorsomedial and the anterior nuclei of the thalamus, the limbic cortex, so the cingulate and the parahippocampal gyri, and the olfactory structures. Okay, and there's a couple important clinical correlations that you should know. Again, so this is a just to better orient ourselves. This is a superior view of the cerebrum. This structure here, this entire thing is the hippocampus. At the end of the hippocampus, you get the amygdaloid bodies. The fornix here is right here uh, at the top. And again, this is the hippocampal commissure. Okay, and again, this is a picture that you should be more familiar with. So all of this is the corpus callosum. Again, this is the cingulate gyrus, so it's right above, right superior to the corpus callosum. Okay, and the para hippocampal gyrus, I guess we'll see in the next picture, inshallah. All right, but this is the fornix too. This is the fornix. Okay. A lesion in which of the following labeled structure would lead to anterograde amnesia? Okay, so take a minute. So the answer is A. Okay, does anyone know why anterograde amnesia? Try to think about it for a second. First of all, let's discuss what these other options are. So D is the pineal body. C is the orbitofrontal cortex. It has nothing to do with memory, more to do with like personality and stuff like that. B, you see this. This is the globus pallidus interna. Okay, and this is the hippocampus. Okay, so the anterograde amnesia is the inability to form new explicit memories. First of all, I want you to know before we get into the limbic system too much, I want you to know that most of these or a lot of these limbic structures are in the temporal lobe specifically, especially the amygdala and the hippocampus. This is important to know for one disease process that we're going to talk about very soon. Okay, so temporal lobe, remember that. So anterograde amnesia is the inability to form new explicit memories. This can be caused by bilateral hippocampal lesions or thalamic infarction. Okay, so the thalamic infarction we talked about before, but the bilateral hippocampal lesions, which we see here, for example, this is the hippocampus here, or this, okay? It's seen in HSV-1 encephalitis, so herpes simplex virus 1 encephalitis. Why? Because it targets the temporal lobe. Okay, that's why in another disease, in another syndrome that we'll talk about soon, where the amygdalas are affected, it could also be caused by HSV-1 encephalitis because the temporal lobe is where the amygdala and the hippocampus are. Okay, so again, anterograde amnesia is the inability to form new explicit memories. Okay, you might remember that we have two forms of memories, and anterograde amnesia is an inability to form any new explicit memories after the time of the lesion or the disease process. Okay, now the next disease that I want to talk about is the Wernicke-Korsakoff syndrome. The main thing that's affected in Wernicke's-Korsakoff syndrome are the mammillary bodies, which we'll talk about in a minute. But again, Wernicke-Korsakoff syndrome is the combination of two diseases at once. You get Wernicke's encephalopathy and Korsakoff psychosis. Wernicke's encephalopathy is much more long-term thing. So this is usually Wernicke's-Korsakoff syndrome. Usually it's because of chronic alcoholism, okay, of the same disease, right? So chronic alcoholism. Wernicke's encephalopathy includes mental changes because of loss of the dorsomedial nucleus of the thalamus and abnormal eye movements and gait ataxia. Because again, what did we say about chronic alcoholism also can cause anterior vermis syndrome, right? And again, why is the dorsomedial nucleus of the thalamus affected? Because if you remember, we talked about before, it's responsible for emotional behavior, the dorsomedial nucleus of the thalamus. Okay, so that's why you get mental changes. Okay, now Korsakoff psychosis has anterograde short-term memory loss, which may be combined with retrograde amnesia and confabulations. So confabulations is patients would have gaps in their memory. They're not able to fill those gaps in their memory. They don't know, they don't remember a lot of things. So they're going to make up lies, but to them, they're not lies. They're just trying to subconsciously fill in the gaps of their memories. Okay, so they're going to make up stories about events that never occurred. And you get degeneration of the mammillary neurons in the Korsakoff syndrome. So the mammillary neurons, I think we have a slide on it back here. Yeah, so this is the mammillary bodies, okay, here. And again, these are all in very similar places when we look at like a coronal section, for example, of the uh, of the brain. Okay, so main thing that I want you to know, degeneration of mammillary neurons occurs in Korsakoff syndrome and is commonly associated with thiamine deficiency. This is vitamin B1 deficiency. Okay. You'll learn about this disease, inshallah, in next year in more detail. But for now, this is good enough for you to know. Okay, so who knows what the diagnosis is here? Here we have hyperorality, where this patient, or this Mr. Bean, I guess, is putting things into his mouth. We have a lesion in these structures here. We have hypersexuality and loss of fear. So I'm not sure if you can tell, but this is a monkey who's reaching out from his window and he's grabbing a snake. And monkeys have a natural fear of snakes. So this patient has this specific disease and he has loss of fear. So this is Kluver-Bucy syndrome. Or in other words, this is a bilateral amygdala lesion. Okay, and amygdala is responsible for a lot of the personality, a lot of the inhibition, you know, in your personality. So if you get bilateral amygdala lesions, you're going to have a lot of very unique clinical manifestations like increased oral exploratory behavior, hypersexuality, and if the hippocampus, because again, we mentioned that the amygdaloid bodies are very close in relation to the hippocampal body. So if the hippocampus involved, also obviously these patients can also have anterograde amnesia. And this is the disease that I was talking about that could also be caused by HSV1 encephalitis. So pay attention. If it's temporal lobe, encephalitis, just know that the amygdala and the hippocampus can be affected. Okay? All right. All right, and that is it for this PAL session. Hopefully you guys learned something. Please don't forget to scan the code and let me know how I did. And yeah, thank you guys so much for listening, and we'll see you soon, inshallah.